Okay, Excellencies, ladies and gentlemen. Okay, Excellencies, ladies and gentlemen, please be seated in front of your laptop or computer because in a few minutes the opening ceremony will proceed in no time. Thank you. Assalamualaikum warahmatullahi wabarakatuh. Honorable Director of POLTEKKES KEMENKES Malang, Dr. Budi Susatya, SKP MKes, our speakers for today, adjunct lecturer in midwifery and nursing from Flinders University, Professor Kristen Graham, Vietnamese interpreter for patient service, health service document translator, and patient service support from Joshua International Healthcare, Taipei, Taiwan, Professor Pan Tan Phu, Professor from School of Pharmacy, Research Center for Nanosciences and Nanotechnology, Institut Teknologi Bandung, Dr. Heni Rahmawati. Lecturer of POLTEKKES KEMENKES Malang, Dr. Arif Bahtiar. Our moderator, Dr. Nur Rahman. All invited guests, participants, and audience. First of all, let's praise our God, the most gracious, the most merciful, the creator and sustainer of the universe. Selamat pagi. Good morning, ladies and gentlemen. My name is Shifa Nuraisha. It is an awesome and precious chance for me to be your master of ceremony on the second day of the third International Conference on Food, Nutrition, and Health 2020 in celebration of 19 Disnatalis of POLTEKKES KEMENKES Malang. Ladies and gentlemen, before we start with our first agenda, I would like to inform all participating guests participant and audience, either via Zoom or YouTube channel, please fill in the attendance form at the following link.
Assalamualaikum warahmatullahi wabarakatuh.
Okay, so you can fill the form at bit.ly/attendance third ICFMH. Once again, you can fill the form at bit.ly/attendance third ICFMH. Okay, thank you. And now we will start our session on the second day of the third International Conference on Food, Nutrition and Health 2020 that will be led by the representative of Komite, Dr. Nur Rahman, STPNP. I will introduce him first. Dr. Nur Rahman is a lecturer of POLTEKKES KEMENKES Malang. He currently holds a position as a coordinator of COA, Center of Excellence, IPE and IPC. Dr. Nur Rahman received his doctoral degree from Institut Pertanian Bogor in 2014. His interest is in doing research in the field of food technology, and recently he did research on giving cocoa ice cream and tea to experimental animals in 2019.
Assalamualaikum warahmatullahi wabarakatuh. Thank you, Mr. Officer Jessica, for the opportunity. Good morning to the honorable panelists participants. Welcome to our webinar, International Conference on Food, Nutrition and Health of Polytechnic Kesehatan Malang. I'm Rahman from Polytechnic Kesehatan Malang as the representative of committee. I will be responsible to lead this discussion in this webinar. Before coming to the material session, I would like until the end of the webinar. Second, every participant in the Zoom meeting are prohibited to unmute themselves during the speaker presentation and can unmute when allowed. Third, a question can be typed via chat box under the format name, institution, and question. Fourth, information such as material link and other can be accessed via the chat box. That's all the rule for the webinar. Then I would like to say thank you for being here this morning. Now, entering the first presentation, today we are pleased to welcome Prof. Kristen Graham. I will read the professional qualification. I will choose the most recent one or some of them. Understanding vaccine and the National Immunization Program, 2004, Master of Professional Education and Training in Taking University, 2000, Master of Public Health and Tropical Medicine. And her employment history are, it's many, but I will choose some of them. In August 2020 to date, Casual Academic Central Queensland University, August 2020 to date, Research Assistant, Casual Taken University, July 2020 to date, Academic Researchers, Casual University of South Australia. And September 2010 to 2020, lecture in nursing and midwifery full-time, in Flinders University.
Prof. Graham Awards 2017 Vice President or Executive Dean Award Education Academic Staff Level, and 2001 Student Midwife of the Year. Her professional activity, I will read some of them. Trans-Tasman Midwifery Education Consortium, an Australian College of Midwife, member of SA Band Education Committee, and Nursing and Midwife Group of Australia Expert Advisory Group, Midwife Standard for Practice. Prof. Graham grants are for Flinders University Australia Award Fellowship Strengthening Indonesian Community and Primary Service Complication Readiness to Improve MNCH Outcome. And 2014 Flinders University Australia Award Fellowship Building Research and Clinical Education Capacity for Health Professional in Indonesia. And 2014 the Smart Mom Project, Universitas Airlangga and Flinders University collaboration. And many student research supervision. I'll not read all, and I will. Prof. Graham, how are you?
I'm very well, thank you, and thank you for inviting me to speak today. I'm really excited.
Okay, thank you, Prof. Graham. You have joined this morning. Today, she will be sharing with us her expert opinion on update on evidence-based practice in midwifery. With that, I ask to all participants to give full attention to Prof. Graham and help me in welcoming her to the stage. Prof. Graham, time is yours.
Good morning, everybody. And again, thank you so much for inviting me to speak this morning on behalf of Flinders University. Flinders University has had a long history of working in partnership with colleagues in Indonesia. And so I'm very excited to be able to be part of a new partnership with your Polytechnic, which is fantastic. So I've been asked to speak today about evidence-based practice in midwifery. And that's really exciting for me because as an educator and as a researcher in midwifery, and having worked around the world in such places as Thailand and Sierra Leone and Timor-Leste and most recently working in partnership in Indonesia, the need for evidence-based practice in midwifery is just fantastically huge. We need to make sure as midwives that the care that we are providing to women and babies and their families around the world is evidence-based. And we have wonderful opportunities as midwives, whether you're a clinician or an educator or a researcher, to contribute to that body of knowledge and improve healthcare around the world. So my presentation today, we will look briefly at what is evidence-based practice, the importance of evidence-based practice, what is some of the midwifery evidence, and so what are some important considerations that need us to ensure that we have good evidence behind the practice that we provide, and some barriers and enablers for translating evidence into practice, because just because we have the evidence doesn't necessarily mean that that is well translated into clinical practice. One thing that I would really like to remind everybody of, those of you who are potentially not midwives, but those of you who are midwives will know that midwifery is a science, and we certainly do need to base everything that we do on evidence to ensure that our practice is safe. However, midwifery is also an art. And over the years, like traditionally, midwifery practice was passed down from mother to daughter. And it's only fairly recently that that midwifery has been recognised around the world as its own unique profession, separate to nursing. And And so we are actually developing a body of knowledge that is quite young. So we're a fairly young official profession. However, we have a very, very long history, thousands of years of history, in fact. And so we need to celebrate that midwifery is very much based still as an art and in the intuition and wisdom of midwifery, but we need to marry that up with evidence. And this is one of the early textbooks provided for midwives, which is going back quite a long way. So what is evidence-based practice? Well, evidence-based practice is a problem-solving approach to the delivery of healthcare that integrates the best evidence from research studies and patient care data with clinician expertise and patient preference and values. When delivered in a context of caring, which is what midwifery is all about, and in a supportive organisational culture, the highest quality of care and best patient outcomes can be achieved. And it is really important to remember that evidence-based practice isn't just all about research. Midwifery, as I said, it's an art and a science. And so we need to make sure that we have good research evidence that underpins everything that we do, but that we don't forget about the importance of clinical experience and expertise. And that we certainly don't forget about the need to provide contextual care and to take into consideration the patient's, or in midwifery's case, the woman's values and preferences for her care. Everything needs to be, like the woman needs to be central to all of the care that we provide. And so we must combine all of these three aspects in terms of the provision of evidence-based care. Research evidence really should not override the woman's preference for care. She has the right to the care that she wants, and we need to take that into consideration. And sometimes, you know, a midwife's intuition is very important. Sometimes we just can't quite pinpoint what's happening, and we need to make sure that we are certainly using our clinical expertise as well. So all three things are very important to evidence-based practice. Now, the importance of evidence-based practice in midwifery is paramount. Evidence actually informs policy and clinical practice, and all of the guidelines that we have, whether they be in a hospital or whether they be broader health system guidelines, we need to make sure that they are based on contemporary evidence, not things that we think work, not things of the way that we always used to do it, but they must be underpinned by research evidence. And you'll find that many decisions that are made sometimes in hospitals are not necessarily based on the latest evidence. So it's also important to ensure that we use evidence-based practice to make sure that women receive the care that is specific to their unique needs. So again, we need to be thinking about what does that research, what does that expertise mean in relation to their own unique needs. We need to, the importance of evidence-based practice helps to facilitate sound decision-making and to minimise risk. If you've got a strong underpinning research basis for your decisions, if you've got guidelines that help you to make decisions and those guidelines are based on evidence, you will actually provide sound practice that is less likely to cause harm. But instead to promote the best, healthiest outcomes that we can achieve. Evidence-based practice reduces unnecessary, ineffective, and possibly harmful interventions. One of the things about midwifery is that we are the protectors of normal birth. And so you'll find that in many countries around the world, it's particularly here in Australia, but there are some countries that have exceptionally high medical intervention rates for women who do not necessarily need them. The World Health Organization states that 15% of women are most likely to need emergency intervention through childbearing, but the remainder will likely have really good normal birthing outcomes. However, we have some countries whose caesarean section rates are 35, 40, 50, 60%. And that's not what the World Health Organization recommends. So we need to be basing our decisions not on fear, but on evidence Do we need to intervene, or do we just let nature take its course? Sometimes absolutely yes, but midwives need to advocate for normal birthing and to try and minimize interventions, because those interventions, once we start meddling with normal, we usually need to intervene more. And that can lead to harmful outcomes. Evidence-based practice provides justification, as I said, for clinical decisions and actions, so that if you are doing something or you're suggesting care to a woman, or suggesting care and someone questions what you're doing, you have the evidence to back up your decision and justify your care. And it's certainly evidence-based practice. It helps build the professional body of knowledge and professional integrity. Midwifery, as I said before, is a fairly young profession in terms of recognition as its own profession, and we need to build up that body of knowledge and have not nursing research, not medical research, but midwifery specific research, because that is what makes a profession a recognizable profession, and that is what makes us a respected profession as well. There's nothing worse than going and talking to somebody about the care that you want to provide and have no evidence to back up your rationale for wanting to do that. And so we need many more researchers in midwifery to build up that body of knowledge and professional integrity. Now, as you would know, we are very much bound in terms of midwifery by regulations, standards, and priorities. And I just wanted to pop this up here as a reminder that as a profession, we need to be basing everything that we do on evidence. And we also need to be promoting that in our curriculum. So all of the students that are coming through midwifery programs, we're wanting to embed evidence-based practice into their very professional being. And so here in Australia, we're all bound by the International Confederation of Midwives. They are our internationally recognised professional body, and their focus on evidence-based practice is very obvious in all of the documentation and their philosophies. In Australia, we have the Nursing and Midwifery Board of Australia, who keeps the midwives in line, and they're our registration body. And the Australian Nursing and Midwifery Accreditation Council ensures that we have curriculums for midwifery students that are based on evidence. In Indonesia, you have a many number of different organisations and councils who rely on the care that we're providing being evidence-based, and they would certainly everything that all of their philosophies and principles would be based on the similar sorts of requirements for evidence-based practice. So here, just as a reminder, and I always pop these slides up because I think it's always a good reminder to know what is happening in our internationally, is that when it comes to education and when it comes to practice, that the International Confederation of Midwives has a tremendous amount of information and resources to help us to ensure our programs are based on evidence and that we're providing evidence-based care. And so they have the global standards for midwifery education, and evidence-based practice is threaded throughout that. And even the competency framework for midwives who are practicing around the world does expound the need to actually have all of our practice based on evidence, and to ensure, again, that it's woman-centred. I can't stress that enough. So here you can see evidence-based practice in the ICM competencies. It states that the ICM competencies promote autonomy, the role of the midwife to support physiology and promote normal birth, to uphold human rights. But you can see here in green, the role of the midwife to promote evidence-based practice, including reducing unnecessary interventions. And if you're ever questioned about wanting to promote normal birth, wanting to reduce unnecessary interventions, you have this to go to. Say, well, this is what the International Confederation of Midwives promotes us and wants us to do. And so always, use this as your evidence as well for some of the professional activities that you undertake. I know a lot of you are midwifery educators, and or if you're an academic working in a polytechnic or a university, or you're a facilitator or a clinical educator or a clinician who supports midwifery students out on placement. As we are all educators, and as educators, we have to prepare midwifery students to be workplace ready. And to do that, we must support them to develop professional knowledge, skills, and attributes. That means that they're safe practitioners, that they're confident in the provision of safe, effective, and professional care, and that everything that they do reflects evidence-based practice. Where as clinicians or educators, we must make sure that we're giving them opportunities to learn about the evidence, to interpret the evidence, and make sure that what they're finding actually is appropriate evidence. But how do they also then translate that into practice? A lot of students at Flinders University, they tell me, Kristen, you've taught us this, we know it's evidence, but when I go out into the clinical workplace, the midwives there are not doing it. They're doing things in the old way, the things that they learned 20 years ago. And what do? They're telling us, no, you're doing it the wrong way. What is that university teaching you? And so they actually ask for advice. How can they actually take what they have learned, which they know is right, which they know is evidence? How do they go into the workplace and take that evidence with them without being told off or people feeling uncomfortable about it? And that's something really difficult as a midwifery student, as you can imagine. And so it's really important that we give them the skills to be able to do that as well as educators. But we need to make sure that they really are well grounded in the need for evidence-based practice. And just so you know, some of these pictures that I have up here, this is our wonderful, this is some of our Australia Award fellows who came from Indonesia, from UNAIR and MH Tamarin and Polytechnic in Kupang. And this is our Mama Victoria Spice, who is our simulation mannequin. And so this was really fantastic, doing some simulation with them. But when we do simulation, we embed evidence into all of that care and make sure everything's done correctly. So a couple more resources, things that you might like to look, certainly the midwifery education priorities are looking at the UNFPA, UNICEF, WHO and ICM document on the framework for action about strengthening quality midwifery education, again, making sure it's evidence-based and that's integrated everywhere. And even the midwifery educator core competencies, we again need to make sure that everything we do is based on evidence and reflects that woman-centeredness and that intuition as well, the expertise midwives actually have, and learning to trust that. So in regards to evidence-based practice, there's 5 steps. So you'll see that there's, if you're trying to find out the evidence yourself, then there are 5 steps to actually finding those answers. So the first step is formulating a well-built question, actually knowing what you want to find out so that you'll find appropriate evidence that's specific to that. And then identifying articles and other evidence, so research articles, but other evidence that might be available to make sure that you can answer the question. So finding the evidence is an important part of evidence-based practice, and anybody can do that. And we need to teach students and our colleagues how to do that effectively. Once you've identified some articles and other evidence-based resources, you need to critically appraise the evidence to make sure it's valid. Not everything's valid. There are some research articles that you read and go, that does not actually sound good to me. Maybe the methodology hasn't been done correctly, or there's some problems in terms of the analysis. So there are lots of different tools you can use to actually appraise the evidence to make sure it is appropriate for you to then base your practice upon. Then the next step, of course, is applying the evidence. And later on, reevaluating the application of evidence and areas for improvement, because not every research study that you read is necessarily appropriate to your own context. Midwifery in Australia is a bit different to midwifery in Indonesia, which is a bit different to midwifery in Africa. So there's lots of different things that we need to take into consideration, because we might need to get more specific evidence, and that provides an opportunity. Going back here, applying the evidence, this is something that we do need to support each other in doing, because evidence, once somebody has got sort of determined new research that should be saying, well, this is the best way of doing it, it can take up to 15 years for that research and that application and that best practice to actually become commonly used in a clinical area. 15 years is a long time. So you can see change is not always easy. It can take a long time. And so this translation of evidence into practice or applying the evidence is a really important step. And there's a lot of research that Flinders is actually undertaking at the moment on how do we do that. It's all well and good to do research and to find best practice and good evidence, but actually translating that and getting that out into the workforce and into clinical practice is quite difficult. And so there's a specific movement around how do we do that? What's evidence on getting evidence-based practice into clinical areas? A lot of you would have seen this already, I would imagine, that there is an evidence hierarchy. So when you are looking for research evidence for best practice, you need to be looking at what types of evidence you are looking at. So not all evidence is equal and not all evidence is appropriate to inform practice and policy, which is why you need to critique it and look at it carefully. So evidence has been ranked by health scientists, academics and clinicians according to its quality as evident in this hierarchical pyramid framework. So you can see below, expert opinion and editorials in journals, they're quite common. Sometimes they've got some great information, but they're right at the very bottom in terms of how high they are in the evidence hierarchy. And so as we go from the bottom up, so case series, case reports, very interesting, not necessarily, really high level evidence though, to case control studies, cohort studies, randomized control trials, and then systematic reviews and meta-analyses that really just pull information from many, many different resources and have a broad range of generalizability. And so this is what we're really aiming for, these top things to be looking at in terms of forming evidence-based practice. So in Australia and around the world, there's lots of different things where we really, priorities for evidence-based midwifery practice and priorities for research, where there's lots of uncertainty and we just, maybe need to be able to get some more research evidence. So models of maternity care is a really important one. And there's evidence to show that midwifery practice, especially continuity of care, is very beneficial for women. And it's very beneficial for the health outcomes of mothers and babies. Infection control in COVID-19, what is best practice and what is the evidence in making sure that we are reducing the risks of transmission? Of course, Australia is doing reasonably well. We're very fortunate here in terms of our responses and our cases. And I know Indonesia is having a tough time in many areas, as are places in Europe, as are places in other places in Asia and of course America. And so knowing what is the best way of treatment for COVID-19, what is the best infection control measures, how do we reduce community transmission to try and get this done? How do we care for women effectively when we need to socially distance? So we need really good evidence. And at the moment, there's a lot of studies being done in that area to be able to determine that. Medication administration and pain relief in labour are two very important things. In South Australia, I have a colleague who works for UniSA who has provided some amazing evidence about the use of fentanyl in labour as opposed to pethidine. And she has actually integrated this into hospitals where women are in control of their own fentanyl, which is a narcotic, and they spray it into their nose, which means that they can take it whenever they want instead of waiting for an injection. And it provides much better pain relief and much better outcomes for the baby as well. So fantastic research, but not everybody is accepting that as a possibility for women. So that's something that we're wanting to get out there much more. Things like fetal monitoring. When should we do it? When is it appropriate? How should we react? Should that be the only thing that we are using in terms of determining fetal distress and if someone needs a cesarean section? And nutrition in labour. Should women be allowed to eat? Or should they be fasted? Or should they just have chips? And so those are the sorts of things that we do have evidence about, but making sure that that's translated into practice. So what are the impacts of effective translation of evidence into practice? So what impacts effective translation? There's lots of barriers, and certainly workplace culture and expectations are a significant one. As I said before, many midwives will say, but this is the way I've been doing it. It works. Why change? Okay. It's like, because it's not the best practice. There are better ways of doing things. Just because you've done this for 20, 30, 40 years doesn't necessarily mean that is the best way of doing it. You might not be harming women, but you might not be providing them with the best care either. And there are other people who go, it's just too hard. It works. It's okay. We get by. It's just we're too busy. And so they don't want to change. There's often discomfort and distrust about change as well. And especially if you've got, again, a workplace culture that does not promote change and welcome it, there certainly is a distrust that, they're just changing it because they can, not because they need to. There are certainly time and budget constraints that we need to consider whenever we are trying to translate new evidence into practice or make any change. And also there's interprofessional resistance to change. And I'm not sure what it might be like in Indonesia, but in Australia, midwives and doctors, we work very well, and we're trying to promote collegiality and joint decision-making. But there is a long history between doctors and midwives. There's a little bit of tension because midwives are trying to protect normal and remain autonomous and build their own body of knowledge. And doctors have a long history of being in charge. And when we're moving towards midwifery-led care in Australia, that is met with some resistance. And so when you're trying to build collegiality between two disciplines, it is actually really important to say, well, yes, we do want to do this, and we've got the evidence. We actually have this great evidence behind us. So let's talk it through, pull our evidence and see what are the best ways forward. Certainly poor communication and support of change is a major factor that impacts the effective translation of evidence into practice. And a lack of access to best practice evidence is huge. I know there would be many clinicians who just don't know how to access research articles, and many of them can't access them because they don't have access to the databases. They're too expensive. I work in a university. I can access pretty much anything I want to through the university, but not everybody has that access. And so one of the things that's wonderful is to see more people having open access research journal articles made available. However, that costs money. It's quite expensive to actually get an open access article published, but we need to make this actual evidence available to everybody. And that will decrease the distrust about evidence, I think. So a couple of things to help translating evidence into midwifery practice. First thing is to promote a workplace culture which embraces evidence and best practice. That's what we need here. We want, you want a really good workplace culture that goes, yep, we want to provide the women and babies we're caring for with best practice care. We need to have a workplace culture that empowers midwives and nurses in evidence-based practice. Again, that they have that access to resources, that they actually are able to be involved in research activities as well themselves, and quality improvement projects that will help to develop this body of knowledge. And we need a culture that embeds evidence-based practice in education and training. I hear stories, sometimes even tutors that are coming into universities, they're not teaching the latest evidence. They're teaching what they do in the hospital, which is often what they're comfortable with, which might not be the latest evidence. So we need to make sure that whenever we're doing education and training, it is based on contemporary best evidence, not just what we're comfortable with, and know that it's okay. We need to integrate evidence into policy and guidelines and make sure that they're kept up to date. That's really important. Here in South Australia, we have the perinatal practice guidelines that are updated every couple of years by senior clinicians. And we actually get our students to review them as well. And that's a really good academic and scholarly activity. We need to provide clear communication of changes, evidence, and expectations. That transparency is really important, and not just implementing changes in practice because we can, but actually giving the background as why this is best practice. We need to provide appropriate resources, so money, time, etc., to implement this practice. Provide evidence of improvements of improvements that have been achieved through evidence to show that it actually works. We can improve health outcomes, and we've done that because we've implemented this change that is based on best practice. We need to promote partnerships between researchers, academics, students, and clinicians. And those are really powerful. And in Australia, we actually have a lot of professors from the university who work in the hospital. And that's part of their job, is to work with clinicians on research and to help them embed best practice into their workplace. It's really exciting. And we need to empower and support midwifery change agents. A lot of people don't want to try and change because they get knocked down. You know, people go, oh, you're just giving me more work to do. I don't want to change. Just leave me alone. But we need to have a culture where we've got, change agents who are willing to stand up and help people to integrate best practice into our workplaces. So just finishing up, as I said before, in terms of evidence-based practice, it is really important that we remember that it isn't all just about research, that there is what Hannah Darlin, who's a bit of a midwifery guru here in Australia, what she describes as the triangle of wisdom for midwifery practice, that we actually ensure, again, that whenever we are providing midwifery care, that we look at what does the evidence say down here in the bottom. What does the evidence say about, this particular decision or care that I'm going to provide? What has caring for other women taught me? What is my expertise, my experience telling me about this particular care or this context? And really importantly, what does this woman want? And that triangle of wisdom, when we use evidence-based practice, will actually keep us safe. It'll prevent us from being fearful about the care that we provide, because everything that we do is in the circle of wisdom. Where we have justifications for the care that we provide, but we're making sure that we think about our intuition, our own wisdom, our own experience, and again, what does the woman want, to make sure it is evidence-based, woman-centered care. So this year, we're drawing to an end of 2020. And I think, thank goodness, really, it has been a very difficult year. And who would have known at the beginning, when the World Health Organization announced that 2020 was the International Year of the Nurse and Midwife, and what an amazing year for there to be real evidence of just how important nurses and midwives are to the care of women in this COVID-19 pandemic. But I really do want to celebrate that 2020, the recognition of how important nurses and midwives are. And now more than ever, the entire world needs skilled midwives to provide woman-centered care and to provide leadership in research and best practice to improve health outcomes for women and babies. And if we do that, if we get more midwives, if we have people who are really committed to evidence-based practice and best care for women and babies, we can make an incredible difference. So let's celebrate that and move forward and create more evidence and get that out into clinical practice so it benefits women and babies. So Terima kasih, thank you so much. And I think we have a little bit of time for questions, I believe, Dr. Nair.
Thank you, Prof. Graham. It's a very interesting presentation and inspiring presentation. I hope it's a positive. It gives positive stimulation for participants and for all us. And more better understanding, I would like to ask the interpreter for in Indonesian conclusion for Prof. Graham presentation. To Mrs. Ika, time is yours. Halo, Mrs. Ika.
Fine, okay. Pak Nur, terima kasih. Thank you for the time given by Pak Nur. Very awesome presentation, Mrs. Graham. Dear ladies and gentlemen, please allow me to provide a summary of the material that has been delivered by Mrs. Graham in Indonesian. Jadi topik ini adalah tentang praktek terbaik dalam kebidanan yang berbasis pada bukti penelitian. Definisi dari evidence-based practices adalah suatu pendekatan pemecahan masalah kesehatan yang mengintegrasikan antara bukti ilmiah terbaik dari penelitian dan keahlian dari tenaga kesehatan, kemudian disesuaikan dengan keinginan dan value atau nilai-nilai yang dimiliki oleh seorang pasien. Kemudian kebidanan ini adalah salah satu profesi yang tertua di dunia yang menggabungkan antara ilmu pengetahuan dan seni. Karena digabungkan dengan seni, maka ilmu kebidanan itu tidak statis ya. Artinya dia harus selalu mengikuti perkembangan praktek terkini yang sesuai dengan hasil-hasil penelitian. Kenapa bidan harus menggunakan atau mengaplikasikan evidence-based practice di dalam asuhannya? Nah, ini sudah ada regulasinya ya Bapak Ibu. Jadi baik itu dari ICM, Organisasi Kebidanan Internasional, di dalam dokumen Global Standards of Midwifery Education, di situ kita bisa lihat, dan juga pada dokumen yang diterbitkan oleh Ikatan Bidan Indonesia, yaitu Standar Asuhan Kebidanan. Di kedua dokumen dari organisasi bidan itu termaktub kewajiban bidan untuk memberikan asuhan sesuai dengan evidence-based practice. Kenapa perlu untuk melaksanakan IBP ini di dalam asuhan kebidanan? Yang pertama, untuk memastikan perempuan atau klien mendapatkan asuhan kebidanan sesuai dengan kebutuhannya. Kemudian untuk mengurangi intervensi yang tidak diperlukan, intervensi-intervensi yang berdasarkan pada kebiasaan, bukan pada kebenaran bukti ilmiah. Kemudian juga untuk membangun batang tubuh keilmuan profesi dan integritas profesi. 5 langkah di dalam mengaplikasikan evidence-based practice di dalam asuhan kebidanan adalah, yang pertama adalah menyusun pertanyaan, masalah kesehatan apa yang harus kita cari solusinya. Kemudian yang kedua adalah mengidentifikasi atau mencari artikel ilmiah atau sumber-sumber bukti ilmiah yang dapat menjawab masalah yang sudah kita rumuskan. Kemudian yang ketiga, kita lakukan analisis kritis bukti ilmiah yang sudah kita temukan. Kemudian mengimplementasikan bukti ilmiah yang sudah kita temukan ke dalam asuhan atau praktek kebidanan kita sehari-hari. Dan yang terakhir adalah mengevaluasi penerapan bukti ilmiah untuk melakukan tindak lanjut. Apakah IBP itu sesuai dengan setting pelayanan di tempat kita, ataukah perlu kita lakukan suatu modifikasi. Kemudian bukti-bukti ilmiah banyak macamnya atau sumbernya, dan ada hierarki kekuatan atau akurasi dari bukti-bukti ilmiah yang ada di sumber-sumber referensi. Yang paling tinggi adalah systematic review disusun dengan randomized control trial, kemudian studi kontrol, kohor, kasus kontrol, kemudian laporan kasus, dan yang paling lemah adalah pendapat pakar. Kemudian terdapat praktek-praktek kebidanan berbasis bukti antara lain dalam hal model-model asuhan maternitas yang paling baik, kemudian pengendalian infeksi, pemberian obat, ya, pengawasan janin, nutrisi pada persalinan, dan manajemen nyeri saat persalinan. Kemudian hambatan yang ditemukan dalam mengintegrasikan bukti ilmiah dalam praktek kebidanan antara lain tadi yang paling ngena di pikiran kita itu adalah bahwa kenapa harus berubah gitu kan ya. Kita selalu melakukannya seperti ini dan berhasil, kenapa kita harus berubah? Nah, itu adalah yang paling berat untuk menjalankan ini. Kemudian yang terakhir, jadi untuk menerjemahkan bukti ilmiah ke dalam praktek kebidanan, maka kita perlu membangun budaya kerja yang mendukung asuhan berbasis bukti, kemudian mengintegrasikan bukti ke dalam kebijakan dan pedoman, serta menunjukkan bahwa bukti-bukti peningkatan terhadap keadaan pasien yang dihasilkan melalui penerapan IBP. Demikian simpulan dari materi Ibu Kristen Graham pada hari ini. Terima kasih, saya kembalikan kepada Dr. Nur Rahman.
Thank you, Mrs. Ika. You have
You are very welcome.
okay. You have reading conclusion in Indonesia because many participants from Indonesia. But thank you, Mrs. Ka. But I will read the conclusion of Prof. Graham, that evidence-based practice in midwifery is a problem-solving approach to the delivery of midwifery care that integrated the best evidence from research, midwifery expertise, and patient preference and value. Educator has an important role to develop midwife student evidence-based practice skill for reducing unnecessary intervention and improving health outcome for women and baby. Now entering to the question and answer session, I invite one question from the participant. I will read from the chat box, maybe. Okay. Okay. It's from okay. It's from Yurenda Aurela from Politeknik Kesehatan Malang. I believe evidence-based practice is really important to improve midwifery service. But as you say, it is difficult to translate evidence into practice, but that doesn't mean it cannot right. So I'm curious, how do we get started to introduce intervention or innovation from evidence to practice? Because sometimes it's hard to make a change, especially in midwife area. Patients tend to believe in something already in. Yeah. Then I also would like to ask how we ask the midwife student getting used or habituated with evidence-based practice, cause sometimes a lot of barrier, access, language, etc. Into trust research make us tend to give up. Okay, that is the question from Yurenda. Prof. Graham, time is yours for answer the question.
Thank you. Yorenda, there's some really good questions, and it is really difficult to try and translate evidence into practice. There are a lot of barriers, but you're right. Despite those barriers, we still need to do that, and we need to find ways that are effective. And I think one of the things that is really important is if you've got somebody who's really excited about change, if you've got, especially if they're in leadership positions and they're willing to provide the resources and the motivation and provide the support, if you get somebody on side who is a senior clinician or a group of people, you'll find that people will start to listen because from a leadership level, they're leading the desire and the motivation to incorporate research into practice, and they're helping to make it happen. And so if you've got new research, or if you're thinking that something needs to change to improve the quality and you know the research exists, find a champion in your organization who will help you, who will guide you, who has that influence, and who has the trust of people in the organization, and get them on side to help you to make that change. If you're not sure about what the change should be, well, then find somebody who is a researcher and a leader, an academic, who can help you to determine what is best practice and to look at the literature, and then to be able to present that literature to colleagues. You know, we've got a lot of people who are distrustful, or who just think this is too hard, I'm busy. Midwives are busy people, and it's a stressful profession. And so working with them to say, look, you know, this change won't take a huge amount of work, but it will make a big difference. That's really important. But let me show you the evidence. I don't expect you to read thousands of research articles. I can show you and summarize what the evidence says, and show you and help you to be able to make that change. And so it really is something that, we have to change the culture, and we need to have a transparent process and support people to be able and to want to make that change and to actually make it. In terms of the barriers for midwifery students, it is difficult. I have midwifery students who have often come to me frustrated and sometimes really stressed. I've had students who look at the evidence about for helping someone birth a baby, should your hands be on the baby's head controlling it as it emerges, or should your hands be on the perineum, or should you be hands off? And the evidence says it doesn't really matter. However, we have had a lot of backlash against students who have said, I want to stay hands off. I will guide the woman and watch her and talk her through it. And I'll only put my hands on if I need to, if it, the baby's about to shoot out. But they have had their hands from a midwife put physically on, or if a midwife has said, no, I'm hands off, they slap their hands away. That's not appropriate. And so we need to actually have these conversations that, yes, you might have a preference, but it doesn't necessarily mean it's the only way of doing it. The evidence says it's okay. We've got hospitals at the moment who are blaming 3rd degree and 4th degree increases in trauma on students. It's not their fault, but they have instigated policies to say that you must always be hands-on and you must do this. It's not necessarily based on evidence. We need more evidence to demonstrate that. And so as educators, we do need to provide students with support of how do you manage that? And sometimes it's, you can speak up and just tell them just gently about it or refer them to an academic, or sometimes you just need to stand your ground. And sometimes you just have to go, all right, the battle's not worth pushing at the moment, especially if I'm going to get slapped. So, so providing students with that support and empowerment and knowing what to do is really important. It's not easy. I really feel for midwifery students. Dr. Ne, you're on mute.
Yeah, okay. Thank you, Prof. Graham. The explanation of the question first. And the second question, it's from Mrs. Ika Yudi. The question is, Flander has long collaborated with midwifery in Erlangga. You must have your view on the way midwifery education in Indonesia doing this evidence-based practice to midwife student. What do you think about it? Okay. Please, Graham, time is yours.
Do not laughing.
That is a really good question. I think some amazing things are happening in midwifery in Indonesia, and I'm really excited about it. We have worked with UNAIR and other partners with the support of our Department of Foreign Affairs and Trade since 2014. And a lot of it has been about, like research, how to actually do research and building the body of knowledge and also working collaboratively between midwives, nurses and doctors, which is really important. And so one of my things that I'm so proud of is that Erlangga, the School of Midwifery at Erlangga University, was recently recognised by the UNFPA as a midwifery centre of excellence in research and education. And so they've been doing some tremendous things in terms of working with different education providers in Indonesia to build up the body of knowledge, to provide resources about research, about clinical education, about simulation, all sorts of different things. And I know that they're really committed to research. And we've done a few little things together in terms of trying to look at different ways of doing things and get evidence to show that they work. For instance, around neonatal resuscitation is something that we're working on together at the moment. And so I think, midwifery anywhere in the world, things can always be improved. Australia, Indonesia, wherever we are. But I'm really excited to see the commitment in Indonesia by UNAIR, by APCM, by by all midwifery organisations to really enhance midwifery education, to strengthen it, and to also work with partners who are working in clinical areas to strengthen evidence-based practice. And so if you're wanting support, I would definitely, and you're wanting to partner, I would contact UNAID definitely, because there's some great stuff happening and there's some resources that should be coming available very soon, which they would want to share. Make the most of that. And as I said, I take my hat off to what I've seen in the last 6-7 years in midwifery. It's beautiful.
Yeah.
Lots of challenges like anywhere else, absolutely. But
we have a great passion to learn anyway, Miss Graham, but we have a lot lack of contact. Yeah, maybe I can ask Mrs. Tri Mardianti to establish a contact again with Flinders, so we can maybe I can sit on one of your lecture in Flinders to see how you teach the student midwife.
Ika, I don't actually work there at the moment, so I'm an adjunct there. So I do more research at the moment, but there's lots of opportunities that we could certainly explore. So I'm really happy to have a chat with you about what we might be able to do.
Okay, I'll note that. Okay, thank you.
Thank you, Prof. Graham. But there are 2 questions, but we are running out of the time. Would you like to contact or email Prof. Graham? Hello?
I can, yes, and if you like, I can actually, whilst the next speaker is talking, before I just need to run off to my next meeting, I will try and answer those questions in the group chat.
Thank you. Thank you, Prof. Graham. All right, that was an amazing discussion. I hope it gave inspiration for all us. Thank you for the second presentation. Now we are pleased to welcome to Prof. Pantan. How are you?
Hi, good morning. Can you hear me?
Good morning. Thank you have joined this webinar.
Thank you for inviting me to attend your conference.
Okay.
Yeah, can you hear my voice well?
Okay, I will lead the running webinar.
Okay.
I will introduce your curriculum vitae. His education of Mr. Prof. Pantan Faculty of Department of Hospital Management, Quang Pho University, Ho Chi Minh City, Vietnam, and PhD program of Biotech Healthcare Management, College of Management, International Society of Quality in Healthcare in Taipei Medical University, Taiwan, Taipei. And many education, but I just read only 2, and his working experiment are in University Medical Center, Ho Chi Minh City, Vietnam, Social Work Department, International Collaboration, and organizing medical mission trip to remote area for community healthcare service, evident coordinator for international meeting between UMC and affiliated institute. Then in Joshua International Healthcare Taipei, Taiwan, present Vietnamese interpreter for patient service, health service document translator, and patient service support. And his skill are language skill and research skill, but I don't expand. You can read in the curriculum vitae. And his achievement are, I will choose the most recent ones, that certificate in healthcare leadership and management training course in 2017, and oral presentation abstract, patient support and patient engagement in University Medical Center, Vietnam, Fellowship Graduation Award. And the last, COVID-19 block, patient center care in COVID-19 crisis in Vietnam. So, Prof. Pantan, how are you?
Yeah, I'm fine. So far, so good.
Okay.
So how are you?
Okay, I'm fine too. And today, he will be sharing with us his expert opinion on implementation of an electronic health record system in Vietnam. With that, I ask that you give your full attention to Prof. Pan and help me in welcoming her to the stage. Prof. Pan, time is yours.
Yes. Thank you. Thank you for your introduction, Mr. Nuraman. And welcome all participants. My name is Phan Thanh Phúc. I'm from Vietnam. I'm living in Ho Chi Minh City, one of the largest city in Vietnam. And currently, I'm pursuing my PhD in Taipei Medical University in Taiwan. So I'm just moving from Vietnam to Taiwan months ago. And I'm very happy to share one of the experience from my country. Okay. Can you guys see my screen? So let me
Yes,
begin.
you can see.
Yeah,
Yes.
yeah. Okay.
Yes,
So
it's clear.
yeah, thank you. So let me share my presentation today. So the topic of my presentation is the implementation of electronic health record system in Vietnam. And the presentations were made up by one of my colleagues, and he's not here today. And he said he's the master student, so master student in Taipei Medical University. And the content I gonna present today will give you a short introduction about my country, Vietnam, and about how the healthcare system in my country. And the second one is about the electronic health records implementation, following with its benefit of the implementation and some of our difficulties and challenges. And the last part is about the future outlook. So the terms electronic health records is quite very technical and very widespread, very comprehensive. But in my introduction today, in my presentation today, I just like mention about the administrative perspective, how we implement the electronic health record system, and what is our achievement and what is our difficulties. So we can share the lesson learned from countries to countries. Vietnam is one of the Asian country, and believe that Indonesia also the same region with Vietnam, and we have the population of 96 million. Within among them, 70 percentage of the population are the working age, and our capital is Hanoi. Is in the north side of Vietnam, and my city is in the south side of Vietnam, Ho Chi Minh City. The GDP is about 2,540 per capita, and our growing rate every year is from 6% to 8%, and I believe that we are on the very fast pace of the growing. And the population, within the population, and we have a 70% of the population as working age, which means that we are the young population. And for those number of the young population, most of the people can use the internet very well, and 40% of the population they own the smartphone. That is a good base for the government and for us to implement the electronic health record and the health information system in Vietnam. So for some of our health indicator, we have nearly 9 physicians per 10,000 population, and the total health expenditure is about 6.6% of the GDP. And currently, we have a cover more than 90% of national insurance coverage. On the in the middle of the slide, you can see the level of the healthcare system. So we have a two area. On the left side is a public health facility, and we have a 4 level of the public health facility, including the community level, the district level, and the provincial level, and the central level. And on the side, we have the private sector, the private hospital. For the milestone of the electronic health record system implementation, so the government body is the Ministry of Health, and in June 2014, the Ministry of Health issued the regulation for the basic statistical indices in healthcare. It means that we start to set up the first phase of the health information technology for the nationwide. Before that, we have some kinds of the healthcare facility that is belong to the central level, and the large scale healthcare facility, they develop their own system, and they develop their own electronic medical record. But it is not comprehensive, and it is like separately from the Ministry of Health. So starting from June 2014, the Ministry of Health, they issued the law on the basic statistical indices. And in December 2017, the Ministry of Health, they issue another regulation to assess the IT application at health facility. So related to this document, to this law document, we have the criteria for each level of the health information technology implementation in the health facilities. I will show you in the later chart. And in October 2018, the Ministry of Health officially set up the strategy and plan to implement the electronic health statistic and electronic health the electronic health record system for nationwide. And they have the plan from 2018 to 2020 to implement the pilot system in 15 provinces of Vietnam. Vietnam, we have more than 60 provinces, so one of a part of the location in Vietnam, just the one fourth of the minor part, they got the pilot program to implement the electronic health record system. So in the chart, you can see that we have a 2 block. The lower block, we say it the cover the treatment task, and the upper block they cover the administrative task. So the upper block, they have the central level institute, hospital, or healthcare facility, and the electronic health record system will be implemented within those area, from the grassroots area to the upper area. And the healthcare facility in that level, they will report to the center, to the department at the same level. And the upper level, it is the Ministry of Health, the e-health department. They are responsible for the strategic planning, for the implementation, for the instruction, and they're responsible for the report directly to the Ministry of Health. And they can share the communication, the data, and the achievement to another department that can help to facilitate the electronic health record system within the Vietnam healthcare organization. So for the hospital, the electronic health record system, right now we have some of the current situation. Most of the hospital in Vietnam, most of the healthcare organizations in Vietnam are still maintain the paper-based record, although we got the regulation to digitalize on the record. But with the with nearly like 30,000 facility and 100 million population, it will be a huge work to transform from the paper-based record to the electronic record. And because of the we have the separate vendors, separate hospital and healthcare organization. They develop their own platform, they develop their own system. So the quality of the medical record system is still varies from the department to the department and from the facility to the facility. And that's called the duplicates, the record duplications, which mean that the patient, when they come to the hospital A, they get their records in the hospital A, but it could not share to the hospital B or hospital C. So when they get admitted to the hospital B or hospital C, they have another records for just one person. So it's called the duplication of the medical records. And the current situation is still that we still haven't centralized the electronic health record system. So they have every healthcare facility, every healthcare organization, they have their own electronic medical record. So the plan for the next 5 years should be the centralized on the record system for the better communication and for the better interoperability. On the 100% of the hospitals, they did implemented the health information system, but it's just for the financial, for accounting, for the billing. And as the statistics from e-health department in 2020, there's only 8 hospitals. They digitalize the paper-based record into total electronic health records. For kind of other application, we have about more than 20 healthcare organizations. They have implemented the PASS, one of the system for the radiology diagnosis. And we have 3 hospitals were piloted to apply the IBM Watson for oncology, one of the artificial application for the oncology clinical for the oncology diagnosis. But we still wonder about the quality of this application and need more time to assess the quality of the application. And some of the private institute, private enterprise, they're using the speech recognition data to collect the data from the patient and to collect the data from the physician, but it is very rare. So in the chart, in the current chart, you can see the level of the information technology application at the health facility. For the level 1, it's just the basic health information system. 40% of the healthcare facility they just attain the basic healthcare information system, and for the level 2, they integrate the clinical data research, and another 32% of the healthcare facility they can adopt the level 1, and the level 3 they have a more like the laboratory the laboratory information system and the clinical decision support system in a very basic level. So as you see, for the hospital in Vietnam, we just attain the major number of the hospital. They just attain the level 3, and just a very minimum number of the healthcare organization they attain the level 4 to level 7. It means that you have a PASS system, you become the paperless hospital, and for the level 7, you employ the health level 7 to get the communicate with the between and among the healthcare facilities. And for the vendors, for the enterprise that develop the electronic health record system in Vietnam, we have 2 types of the vendor. The first type of the vendor is we call the governmental vendors. It means that the vendor is belong to the government, and they have a contract with the Ministry of Health, and they support the hospital inside the public system to develop the electronic medical record, the electronic health record system. And on the other side, we have the private vendors. Private vendors mean that including the local vendors and the international vendor or the foreign vendors from China, from Taiwan, from US or from Europe. They will in collaborate with the both public hospital and private hospital to develop the electronic medical record and electronic health record system. So the public hospital, if they are allowed and they get the permission and they get autonomy in financial, they can start a contract with the private vendor to improve the electronic medical record system. So how about the prevention system? This chart is showing the current surveillance and reporting system of Vietnam in infection disease such as the dengue fever or the hand foot mouth disease. So you can see that every level of the healthcare prevention center, they have to detect, they have to do the trial, and they get the report manually and they report to the upper level. So it takes time. It takes a lot of the documentation to report from the grassroots level, from the baseline to the upper level for the administrative, for the analyze and for the measurement. So now we have implemented the electronic communicable disease surveillance system. So this is the interface of the surveillance system, and they can follow and track in real time, and they can provide the measurement, the prevention in real time to prevent the infection, the transmission in the community. And for the national immunization for information system in 2012, we have launched the national NIIS, and in 2016 we started the data initiative that adopt the digital solution. It means that the elders or the parents, they can follow up the data of the injection, of the schedule, or of the availability of the injections for the parents or for themselves online, and it helps them to save the time and save the paper, so they don't need to get out their paper and the schedule book to follow with them. They need to connect to the system on the personal laptop, on their personal computer or mobile phone, so they can follow up exactly the schedule and the timeline for the injection. So what is the benefits of the implementation of the electronic medical and electronic health record system? So you can see that the system have to integrate various type of the practitioner, of the specialist, of the disciplinary, using the communication system, using the electronic medical record. So we call it the integrated health service team. And the benefit from the integration, we have to proact the patient pathway, the healthcare plan, and they will have to emphasize the person-centered care. So they get more connection with the patient. They get more communication with the patient, and the patient and the person, they understand well about their life project and to maintain their well-being, not just for themselves but for the community. So you can see the electronic health record system, they have a huge benefits in this era. So especially we have the wide country with the nearly 100 million people. I think we can share the same situation in Indonesia. So what is the challenge of the implementation? The challenge of the implementation is that we lack of the e-health literacy. We lack of the knowledge of the electronic medical record system, how to adopt the system, how to get the healthcare workers immersed with the system. And the second thing that we do not have the health information management professional officially. Usually we have the computer science staff, but not in the healthcare service. They will transfer from the other industry to the healthcare industry. So it's called a lot of time, and it's called like the miscommunication between the healthcare worker and the him professional. And right now we still haven't got the standard body, and every single healthcare organization, they will follow their own system, their own platforms. It is one of the barriers to the interoperability of the system to share the data. And I mentioned above, the data quality between the healthcare organization, it will be very varied due to the vendor, due to the develop, and due to the platform. And of course, the financial issue, the financial issue, but the funding, the budget is also the challenge to have to develop the electronic health record system. Furthermore, we're also concerned about the patient privacy and the security of the data. We have a lot of lessons learned from the other countries. For example, from Singapore, when they leaked the claim data of nearly thousands of the patient. So when we improve our system, we have to concern about the privacy and the security, and the current IT structure that is not supportive to improve the electronic health record system. So we have to restructure infrastructure of the IT from the facility to the upper level. However, we have a very bright outlook in the future, and I think we can share this outlook between the Vietnam, Indonesia, and the other country in developing country when we adopt the electronic health record system, like big data and artificial intelligence as a very, very potential solution. The solution can help to tackle the overloading situation in the hospital. They have to minimum the health administrative tasks by using the paperwork, use of the paperwork to digitalization work, and they have to mutual the medical research. Since we have the very organized data, we have a very big data of the patient to search for the medical research and for the medical education, and it help the country to well manage the chronic disease and the surveillance of the public health and the community. And in the future, maybe we will like encourage the further international collaboration between the countries to share the lesson learned, to set up the strategy, and to adopt the new technologies from the countries to the country. And those of the issue, they can like improve the awareness and the adoption of the health professional. So thank you for your listening, and hope I can receive a question from you.
Thank you, Dr. Pantans. It's a very interesting presentation, and it's such an inspiring presentation, and it gives positive stimulation for all us. And maybe it's more understanding about your presentation. I would like to some my friends to read in Indonesian translation the conclusion your presentation. Hello, Mrs. Chitra. Are you ready? Okay.
Yes, I'm ready.
Mrs. Chitra, time is yours. You can expand in Indonesian because many participants is from Indonesian. Okay, time is yours.
Okay.
Oh, sorry. So do you need me to turn the slide back so you can do the translation exactly?
No problem. I have written before.
Oh, okay.
Yeah.
I made some minor change on my.
Oh yeah, yeah, just a little. Okay, no problem. Okay, good morning, ladies and gentlemen. Thank you for Mr. Nur Rahman, who has allowed me to summarize Prof. Pantan's presentations into bahasa. I will try my best. Jadi materi dari Prof. Pantan ini membahas tentang bagaimana implementasi sistem perekam data kesehatan elektronik di Vietnam. Kondisi Vietnam saat ini sejumlah penduduknya lumayan padat, dengan 70%-nya adalah usia kerja. Penggunaan gawai dan akses internet meningkat. Rata-rata produk domestik brutonya juga meningkat sejak tahun 99. Kemudian Kementerian Kesehatan Vietnam mulai mencanangkan tentang informasi teknologi di bidang kesehatan sejak tahun 2014 dengan membuat peraturan terkait statistik dasar di pelayanan kesehatan. Kemudian di tahun 2017 pemerintah Vietnam mengumumkan terkait kriteria penilaian aplikasi IT untuk di fasilitas pelayanan kesehatan. Di tahun 2018 pemerintah merencanakan untuk menerapkan statistik kesehatan elektronik, dan sejak tahun 2018 sampai sekarang pemerintah Vietnam sudah mengerjakan pilot project di 15 provinsi untuk menerapkan perekam data kesehatan elektronik. Ruang lingkup EHR di Vietnam itu bukan hanya untuk skop rumah sakit saja, bukan untuk hospital information system saja, tetapi juga selain di rumah sakit juga ada untuk di prevention atau di pencegahannya. Jadi EHR di di Vietnam untuk di rumah sakit atau di hospital information systemnya sampai saat ini masih banyak rumah sakit di Vietnam yang menggunakan rekam medis itu paper base. Kemudian sehingga menyebabkan kualitas rekam medisnya masih bervariasi. Kemudian ada duplikasi karena ketika orang berobat di rumah sakit A, kemudian rumah sakit B akan berbeda lagi rekam medisnya, sehingga akan ada duplikasi dan data itu tidak terpusat. Sementara itu saat ini sebenarnya seluruh rumah sakit di Vietnam itu sudah menggunakan hospital information system, tetapi yang paling sederhana yaitu hanya digunakan untuk billing system saja. Kemudian ada 8 rumah sakit yang sudah mulai melakukan digitalisasi dengan mengalihkan rekam medisnya dari paper base ke EHR. Kemudian ada 23 rumah sakit yang sudah sukses mengimplementasikan PACS, itu untuk aplikasi untuk di bidang radiologi. Kemudian ada 3 rumah sakit yang dipilih sebagai pilot project untuk IBM Watson for Oncology. Ini sebuah artificial intelligence sebagai sistem untuk membantu pengambilan keputusan klinis. Kemudian ada juga pengumpulan data menggunakan pengenal suara atau sound recognizing untuk yang dicontohkan oleh beberapa perusahaan atau institusi. Kemudian dari tadi gambar yang ditampilkan oleh Prof. Pantan juga bisa dilihat bahwa di Vietnam itu sebagian besar Yankesnya masih ada di level 1 dalam penggunaan aplikasi untuk IT, itu masih di basic sistem informasi kesehatan. Selain untuk hospital information system, di EHR-nya juga untuk surveillance penyakit, jadi untuk pencegahan. Jadi ada e-communicable disease surveillance system, itu untuk surveillance penyakit untuk pencegahan. Juga ada sistem informasi imunisasi untuk nasional. Kemudian keuntungan dari EHR ini adalah dengan sistem yang terintegrasi, maka seluruh nakes bisa terintegrasi, sehingga akan memudahkan komunikasi juga memudahkan kontak dengan pasien, sehingga bisa segera mengetahui apa yang terjadi dengan pasien atau masyarakat umum. Kemudian tantangan yang dihadapi dalam EHR ini, kurangnya literatur tentang EHR dan tenaga yang profesional yang paham tentang ini. Kemudian belum ada standar, kemudian kualitas data yang juga belum terlalu baik, kemudian masalah keuangan karena membangun struktur untuk EHR ini membutuhkan biaya yang besar, kemudian juga terkait dengan isu kerahasiaan pasien dan sistem IT di Vietnam. Untuk di masa depan diharapkan dengan adanya EHR ini akan memperoleh big data yang digunakan, yang bisa menjadi dasar untuk artificial intelligence, yang bisa menjadi solusi untuk mengatasi masalah rumah sakit yang penuh, untuk mengurangi tugas administratif yang bisa dikerjakan oleh artificial intelligence, kemudian bisa mengerjakan penelitian di bidang medis menggunakan big data sudah bisa diperoleh, kemudian manajemen penyakit kronis, kemudian surveillance kesehatan masyarakat, dan pendidikan di bidang kesehatan. Juga di masa depan diharapkan pembiayaan terkait dengan ini juga akan semakin meningkat karena memang mengembangkan EHR itu membutuhkan biaya yang besar. Kemudian juga diharapkan di masa depan akan mendorong kolaborasi internasional untuk mengembangkan EHR yang akan berguna untuk masing-masing negara. Kemudian meningkatkan kesadaran atau awareness dari tenaga kesehatan mengenai pentingnya EHR ini. Demikian yang dapat saya sampaikan. I will give it back to Mr. Nur Rahman. Thank you and good morning.
Thank you for your translation.
Thank you, Mr. Fantan. Pak Nur, I'll give it back to you. I have finished my translation.
Okay. Thank you, Mrs. Chitra. It's nice translation. It's because many participant is from Indonesia, so it's more understanding better. And now entering the question and answer session, I invite one question from the first participant. You can write question in the chat box under the format name, institution, and question. Question in English are preferable. Now I will read question from the chat box. There is one question. Okay, I read. Okay, it's from Mr. Ibnu Fajar from Politeknik Kesehatan Malang. He is nutrition background field. How do you see health record implementation in Indonesia? Can it be applied in Indonesia, especially in community basis? Does it cost much to operate EHR system? It needs big national expenditure. What do you think? Okay, that's the question. Please, Prof. Tan to answer this question.
Yeah, thank you for your question. Actually, I don't have much knowledge about like Indonesian system. This is my first time to show up in the Indonesian healthcare worker community to present one of my experience and my knowledge in my country. But I have a lot of colleagues who is the postgraduate student in the Taipei Medical University, and one of my PhD classmates he's from Indonesian too, and I think you have a very big potential. As where your population is like as I know, it's a double as our population, more than 200 million people, right, in Indonesia. So I think this is the trend. This is happening everywhere, every corner in the world. So it's very applicable. We can go from the very basic implementation, from the very basic I show in the chart, like from the level, the very basic fundamental level, and we can gradually develop to the higher level, to get more interoperability and to get more communicative between the hospital and the hospital. And of course, we also say the same difficulties in Indonesia, that the funding for the nationwide system is a huge budget, and I believe that if the government determine to work on the electronic health record system implementation, it will be a success in the future. So that's my answer. Thank you. And I got another question in the chat box. So is EHR in Vietnam include information system about national health insurance in Vietnam? If the answer is yes, how the system work about system information for the national insurance? Currently, the government is working on the claim data, digitalize the national health insurance system. So right now, the national health insurance system is still like in the processing phase. So we haven't integrated the national insurance health system to the EHR system. But in the next 3 years, we work on it. And so after the implementation, if I have the data and I have the result, I can share with you later in the future conference and in the future webinar.
Thank you for the answer.
Thank you, Prof. Pantan. There is a question, maybe. Masih ada? Sudah ya? Oh yeah. There is question from Eko Rahman Setiawan. I will read the question. You mentioned earlier that the national health insurance participants in Vietnam are more than 90%. Please explain about the implementation of the AHR in facilitating the implementation of hospital health service claim for the national health insurance participant.
Yes.
Yeah, please.
Yes, I got the question. I think the question is quite similar to the above question I've been answered. Because the statistics showing that the national health insurance cover nearly 90% of the population, but it's still working paper based, and we are in the processes phase of like digitalize the claim data. And in the next 2 years, maybe after we finish the digitalization of the claim data, we will integrate it to the electronic health record system. So currently, we haven't facilitating the claim data into the system. So after the implementation, if we have any experience or any achievement, I will share with you later.
Of Pantans, maybe it's enough about the question. Maybe thank you very much. All right, that was amazing discussion. I hope it's give inspiration for all us. Thank you, Prof. Pantans. Thank you.
Thank you, and wish you a good time and safe.
Okay, thank you.
See you.
Okay. Now in the short presentation, for the short presentation, this webinar, we are pleased to welcome Prof. Heni Rahmawati, Pharmacy and Master of Science. She is a professor, School of Pharmacy, Research Center for Nanoscience and Nanotechnology, ITB. Her education first a PhD drug targeting and delivery, University of Groningen, Netherlands, and second in 2009 postdoc nanomedicine free University of Berlin, Germany, and second 2010 postdoc nanomedicine National University of Singapore, and the professional experience Prof. Heni, first Chair Division of Nanomedicine, National Research Center for Nanoscience and Nanotechnology, ITB, and Head Study Program of Magister Sport Science, ITB, and 2018 to now Head Study Program of Doctor Pharmacy, ITB. Her publication are national and international, more than 90, and patent one granted 2018, and 7 registered, and 5 book chapter, and her research from 2017 to 2020 are I will just some of them. Development of nanomelinju as a potential anti-gout therapy. The second, development of nano-endospermum for anti-aging, and curcumin nano-emulsive for medical application, and nano-carrier-based gain delivery. And her amazing awards are as a best lecturer in ITB and best lecturer in Dikti and best research Kalbi and Ganesha awards, and the receiver travel grant for Indonesia Innovation Day in Eindhoven, Netherlands, 2017. Also her collaboration program are Nanomedicine Innovation Center of Nanomedicine Kawasaki, Japan, and Nanomedicine Department of Biomaterial Science and Technology, 20 University, Netherlands. And third, MIRA, MIT ITB Research Alliance on Progress, drug targeting for cancer therapy. So, Dr. Henny, Assalamualaikum.
Waalaikumsalam, Pak Nur Rahman.
How are you, Dr. Henny?
I'm very well, thank you, and hope you are also.
Okay, thank you. Today, she will be sharing with us her expert opinion on nano processing on tropical plant to improve their function in food and medicine. With us, I ask that give your full attention to Dr. Henny and help me in welcoming her to the stage. Dr. Henny, time is yours.
Thank you very much, Pak Nur Rahman, for a very nice introduction. A bit longer. Okay. First of all, I would like to thank the organizing committee, especially Pak Nur Rahman as a representative person from POLTEKKES Malang, for inviting me to share our experience in ITB with all of us this morning. And how should I talk in Indonesia or in English?
English, Prof.
Maybe English, yeah, English.
Oh, English.
We must study English.
Okay. Okay, please allow me to share my own presentation.
Okay.
What I sent to committee is still not a final version. Okay, thank you. So here is my presentation. So the title, as Pak Nur Rahman mentioned before, regarding to the nanoprocessing on tropical plants to improve their function in food and medicine. So in this very short time, among our activity, research activity in ITB, which using a lot of tropical plants and processing by applying nanotechnology. So I will only pick up some of them because too many, yeah, too many projects if I have to talk at once. Sorry. Okay, the tropical plant I would like to share with all of you are this one. So the tuber from Colocasia esculenta, we call umbi Jepang, and mangosteen. I think all of you are familiar with these fruits, manggis, and also curcumin. Yeah, so very popular spices in tropical country like in Indonesia. So why nanotechnology is applied for this different kind of tropical plant? Because the benefit of nanotechnology, especially in nutraceutical delivery as well as in drug delivery. Yeah. So we can see here that by using nanotechnology, we can improve the bioavailability of bioactive compound present in natural product. We can protect the product against moisture. We can target the bioactive compound. We can reduce the toxic effect. We can sustain the release. We can improve the texture and the flavor of the bioactive compound, and also, as well as enhancing the solubility. So actually many advantages we can gain from applying nanotechnology in tropical plants. So first I start with mangosteen. So with this mangosteen, we develop nanoparticle from the extract, peel extract. So not from fruit, but from the peel. Because in the peel, we can see potential bioactive compound function as antioxidant. So by applying nanotechnology, we can improve its antioxidant activity. So this is just an overview, regarding to mangosteen. So majority of my slide talking about the experimental aspect. So I hope this will give good experience, or just learn. Maybe you can copy, in your institution for other plants, but the concept is a little bit similar. So we start with mangosteen peel. So as you can see here, so this mangosteen peel contain more or less 50 bioactive of xanthan. So xanthan is kind of a group, in a chemical group, with so very potential antioxidant. But a lot of problem, behind this potential compound. So for example, water insoluble, and this problem actually limit its function, in the health or in the nutrition. So that's why a lot of strategy applied to overcome this problem. For instance, by developing microsphere, microgel, or even nanofiber. So all this solution aim to improve mangosteen alpha, one of the xanthan chemical. So to improve solubility of mangosteen alpha. And what we are doing in our lab, so we, among this method, we develop a nanoparticle, by using electrospinning method. So this slide show the step by step, how to produce nanoparticle using electrospinning technique. So of course, first we extract the pills by using a simple method, mixture of water and ethanol to get xanthan substances. And then after that, we use this extract we call EKM, and we mix together with polymer. So in this case, we use polyphenol pyrrolidine. So we mix with certain ratio. I will show you optimization of the formula to get the best nanoparticle. And then we do electrospinning. So in this electrospinning, a lot of parameter we optimize. So for example, so as you see from here, so the solution itself, so as you can see in here, we optimize different kind of formulation. So the ratio between polymer and the extract, so presented in this table. So I don't want to read one by one, but you can see clearly in this table. And of course, before we do the next process, we just make sure that in this extract there is mangosteen alpha. So we identify the content of mangosteen alpha and using SPLC, and we compare with the mangosteen alpha standard. So this actually used for determining the composition, yeah, the best dose of this extract to get a good characteristic of the product. So first we optimize the solution, yeah, the influence of the solution on the nanoparticle parameter and nanoparticle diameter, as you can see here. So of course, more extract, bigger particle, yeah. So as you can see in this curve, as well as in the same images here. Yeah, this can be understood, yeah, why more extract, bigger particle. Yeah. So this actually the cartoon of the process in the electrospinning method. Yeah, so we of course spray the solution, so the mix between PVP and the extract. Yeah, and this the droplet of the solution will pass electrical field. Yeah, so in the process you can see from, sorry, actually you can see from the previous slide. So here, so when we spray the solution, so in the electrical field where voltage is applied, so we can optimize the voltage to get a best diameter of the particle. Yeah, so as you can see here, then the droplet of the solution will reach the metal plate. Yeah, then we can see particle formation. Yeah. So this particle formation, then we tested, yeah, for different kind of characteristic. So one example is the content of alpha mangosteen, the diameter of the particle, and the morphology of the particle, and also to confirm that after electrospinning, we still have alpha mangosteen, meaning under high voltage of a process, the alpha mangosteen is still stable. So confirm with like FTIR spectrum and also the crystallinity, yeah. So XRD pattern, as you can see here, as well as the thermogram, yeah, thermogram DSG, the differential scanning calorimetry. So all this data actually to confirm, yeah, the process of electrospinning, improving the characteristic of the alpha mangosteen. And at the end of parameter we tested, yeah, is antioxidant activity, of course, because this is the end goal, yeah, of doing electrospinning. So we see better antioxidant activity as compared to the EKM, so the raw material, yeah, before electrospinning and after electrospinning. Yeah, so there is improvement in the antioxidant activity due to improvement in the solubility. And this data was confirmed by this curve. Yeah, so this curve actually showing the release of alpha mangosteen in the simulation of gastrointestinal fluid. Yeah, because the nanoparticle actually aim for oral administration, yeah, to yeah, as antioxidant. Yeah, for example, as anti-aging, yeah, and other antioxidant related therapy. So here, really clear, yeah, curve showing the potential benefit of nanotechnology. Yeah, if you see the comparison of a release pattern between the original extract, yeah, before nanonisation and after nanonisation. So the red line is raw material of the extract, and the black line is nanoparticle, yeah, after electrospinning processing. So from this, I conclude, yeah, that nanonisation of extract from mangosteen showing benefit, yeah, benefit result. And the second example, we also prove, yeah, in Colocasia esculenta. So as I mentioned before, umbi Jepang, yeah, in Indonesian language. So in this plant, we use also electrospinning method, but to form nanofiber, not nanoparticle. Yeah, in mangosteen, we form nanoparticle using electrospinning, and in this plant, we use same technique, but to form nanofiber. So one technique, two different form of nanomaterial. Yeah. So actually, the concern of this process is just to improve the characteristic of protein, yeah, present in this tuber, yeah, in this plant. And the function of the protein, actually, the main function of the protein is to improve cell regeneration. So because of that, so we use this as a membrane, yeah, in the wound healing, yeah, wound dressing. Yeah, so we develop wound dressing made from extract from the Colocasia esculenta. Yeah. Instead of PVP, we use for mangosteen. Yeah, in this extract we use chitosan and PEO, polyethoxy, yeah, polyethylene oxide, polyethylene oxide. So this combination, yeah. So from this we can learn that different extract requires different matrix. Yeah, for alpha mangosteen we need PVP, but for this protein we need different matrix. So for example, in this case is chitosan and PEO. So combination between polymer and polysaccharide actually. Yeah. So what actually the end aim of this process? So we concern with the wound dressing using collagen as a protein, because some people they have allergy with collagen. Yeah, so to replace collagen, we use this plant, yeah, with the same effect, yeah, protein with showing same effect. So as you see here, the function of the protein contained in Colocasia esculenta as antibacterial, hemostasis, and other unique characteristic, biocompatible because from plant, yeah, and also biodegradable, and of course because of biocompatible and biodegradable, so this protein is non-toxic. Yeah. So similar technique, we optimize the voltage, the flow rate of the solution, yeah, and the temperature, yeah, to get the best fiber, yeah, the best fiber meaning good physical performance, yeah, and showing bioactive activity, yeah, as indicated in this box, yeah. Okay. So of course, from different parameter we optimize, yeah, we analyze, yeah, different kind of data. For example, in here you can see the same image, yeah, of different formulation. So here the composition of one solution to other solution, and you can see the influence of composition on the morphology of the membrane. Yeah. So we see beautiful like fiber here. Yeah. So of course we selected the best performance of the fiber. So from here you can see clear separation of fiber, yeah, from one fiber to other fiber, not like here, yeah, So this like melting between one fiber to other fiber. This is not good membrane for wound dressing. And of course, after that, we test the bioactivity. So we use a cell line model. Yeah. So the cell line model actually representing the cell in the skin. So we use fibroblasts. Yeah. So the cell who producing collagen. Yeah. For regeneration when we get a wound. Yeah. So as we can see here in the healthy cell, so the protein not toxic at all. So indicating by the cell viability nearly 100%. So after incubation with the protein extract. So that's why it's actually safe, yeah, for a human. So that's why we can develop this membrane as a raw material for wound dressing. So we also test the attachment of fibroblast cells on this fiber. So why we do this? So this because to see the interaction, yeah, between the membrane and the wound, yeah, in which on the open wound the cell is damaged, yeah, and some tissue is open, and this risky for infection. Yeah, so therefore we close, yeah, the open wound using this wound dressing. And remember that in this membrane there is beside protein from the Escherichia colocasia esculenta also chitosan. Yeah, chitosan we all know that contain polysaccharide, yeah, showing the antibacterial activity. So combination between Colocasio esculenta and chitosan give good purpose for wound dressing. Yeah, as you can see here, the fibroblast cells attach firmly on the membrane. So this good for regeneration of the cell, and then regeneration of the tissue, of course. Okay, so the conclusion of the second part of my talk is that electrospinning method is very potential technique, yeah, to improve the bioactivity of protein present in the Colocasio esculenta as wound dressing. So the third example is curcumin. So I'm not worrying that all people know very well curcumin. Yeah, almost every day we use this, not only for traditional drink, but also for food. Yeah, so in the kitchen we normally use this to color the food. Yeah, but behind that function, curcumin actually very yeah, incredible substance. So I will show here curcumin as a potential spice for nanomaterial. So for that, I will introduce the very recent project, yeah, in our institute using curcumin as a nanomaterial for theranostic application. So theranostic application is also a very new issue, yeah, in the medical field. So the concept of theranostic actually combining diagnostic and therapy at once in the one thing. Yeah. So in one thing, there is a substance function as diagnostic agent, and also substance function as therapeutic agent. But I will not talk in detail because I have limited time. So I just summarize, yeah, the theranostic material. As you can see here, what is the diagnostic component? So we can use radioactive, yeah, or contrast agent. Yeah, so these two substances actually very powerful, yeah, for diagnostic field, yeah, because we can trace the radioactivity, yeah, in the body, as well as we can trace contrast agent by using like confocal microscope. Yeah, and therapeutic component, we can use any therapeutic component, yeah, for anti-cancer, for example, or for Alzheimer or for other diseases. Yeah. So depend on the aim of theranostic itself. Yeah, but recently we can also use natural product as theranostic agent. Yeah, meaning one material function as diagnostic agent, yeah, at the same time as therapeutic agent. Yeah, so as I mentioned before, curcumin, one of them. Other, like here you see different kind of fruit, yeah, banana, orange, lemon, mangoes, yeah. So this all material, yeah, from the natural resources can be as raw material for fluorescent carbon quantum dot. Yeah, so by using a carbonization technique, yeah, either top-down method or bottom-up method, yeah, we can get a fluorescent carbon quantum dot from these different fruits, yeah, and also spices. And what the powerful of this quantum dot? So of course, because this tiny thing can show the color, yeah, and bright color, yeah, fluorescence. So we can use this in the bioimaging, yeah, in the optic electronic, yeah, and also in the biomedicine as well as in the biosensing. So one thing, yeah, for different application. Yeah, so we can trace this quantum dot in the body, and this quantum dot also can act as therapeutic agent. Yeah, why? So as you see here, so the influence of size on the ability to show the color. So this color is bright color, meaning fluorescent. Yeah, fluorescent. So we can detect by using fluorimetry, yeah, fluorimeter, yeah, or by using confocal microscope. So here the bigger, yeah, so the wavelength of this particle also different. Yeah, you can see the blue color, green, yellow, red. So this actually from one material, but they show different color because different size. So this is the unique of this material. Yeah. So the unique of the power of size. Yeah. Here. Because of this one, yeah, because of this various color shown by this material due to size, so we can apply it on different application, yeah, to image, for example, this one, yeah, to visualize the disease, and then to target the drug on that disease, yeah, because if we don't know the location of disease, we cannot get good therapy. Yeah, so that's why theranostic at the moment really good is interesting topic, yeah, for researcher. Okay, so here you can see the advantages using of natural resources for nanotheranostics. Yeah, of course, because from natural, it's so low toxicity. Yeah, and then good cell permeability because of the size is very small. Yeah, environmental friendliness. Yeah, easier to synthesize and functionalize. So just do carbonization, so we will get quantum dot. Yeah. And then excitation depending on the multicolor emission, yeah, depending on the size. Good conductivity, yeah, meaning we can use electrical field, yeah, we can use thermal, yeah, to visualize the disease, yeah, to trace the presence of this quantum dot in the body, and also high chemical stability, yeah. So this all are really important for the nanotheranostics. So in our lab, we use a very simple method. So this is last slide, yeah. So we synthesize graphene, yeah, quantum dot from curcumin. As I mentioned before, curcumin is really powerful. So the method is very simple. So you just heat the curcumin, yeah, at 140 degrees Celsius for 5 hours, and you will get quantum dot. Yeah. So with this quantum dot, you can do many experiments. Yeah, for example, you can incubate different kind of cancer cell, yeah, using this quantum dot. Yeah, you can study the penetration, yeah, using confocal microscope, and many experiments you can do with this quantum dot, with this very simple process. So after, of course, we do characterization. One of the parameter we explore is like the wavelength, the spectra, UV spectra, to see the emission and excitation of the quantum dot. And also we emit using thermal transmission electron microscope. So that's all. I hope very short sharing from our research center will give you overview and insight to do experiment or to do research using natural product present surrounding us. So thank you very much for your attention. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Prof. Hani. It's very interesting presentation and very inspiring presentation, and it's give positive stimulation to all of us. I think many petition from Indonesia. So for better understanding, I would like to ask the interpreter read to the Indonesian translation to the conclusion of Prof. Hani presentation. I asked how are you, Miss Eka?
Fine, thank you.
Are you ready?
Yes.
Okay. Miss Eka will read in Indonesia. Will speak in Indonesia the conclusion of the Prof. Hani presentation. Miss Eka, time is yours.
Okay, thank you. Terima kasih Prof. Hani for the information. Oke, saya akan membacakan sedikit rangkuman dari apa yang sudah disampaikan oleh Prof. Hani tentang nanoprocessing pada tanaman tropis untuk memperbaiki fungsi bahan pangan tersebut sebagai makanan dan juga obat dalam hal penyajiannya. Bisa kita lihat bahwa fungsi teknologi nano untuk nutraceutical adalah meningkatkan daya serap, memperpanjang masa simpan, meningkatkan ketersediaan, melindungi dari kelembapan, dan memberikan ketersediaan yang lebih praktis, mengurangi efek toksik, memungkinkan adanya produk berkelanjutan, dan juga bisa mempengaruhi tekstur dan rasa. Dalam presentasi Prof. Hani telah dibahas 3 bahan pangan tanaman tropis, yaitu manggis, kemudian umbi Jepang, dan kunyit. Pada penelitian terhadap ekstrak kulit manggis, bisa dibuktikan bahwa penelitian nanoprocessing ini bisa memberikan efek positif untuk ekstrak kulit manggis dan meningkatkan aktivitas antioksidan. Kemudian pada pemanfaatan nanoprocessing, terutama metode electrospinning pada umbi Jepang, dapat meningkatkan fungsi wound dressing karena terbukti bisa memecah protein sehingga bisa meningkatkan regenerasi sel. Dan yang terakhir, kunyit sebagai salah satu jenis tanaman terapi yang bisa berfungsi juga untuk terapi teranostik dan terbukti juga efektif dengan nanoprocessing. Mungkin itu saja yang bisa saya sampaikan, Pak Nur. Terima kasih. I'll give it back to you.
Okay, thank you, Ms. Eska, about your explanation, the presentation of the Professor Hani. Now, entering the question and answer session, I invite one question from the participant. You can write question in the chat box under the format name, institution, and question. Question in English preferable. Now I will read the question from the chat box. Okay. First, it's from. Oh, good. It's from Nurhaizan Esa. Do we need to extract specific compound before change into the nanoparticle? And how about the crude extract? Please, Dr. Professor Hani, time is yours.
Thank you, Pak Nur Rahman. So answer in Indonesia or in English?
In maybe Nurhaizan Esa is from Malaysia, maybe. You can in
Oh,
English.
Malaysia, okay. Yeah, of course, to have, so depend on the compound, yeah, the compound we want to explore. So more pure, yeah, much better. So because we, by using extraction process, we remove unnecessary compound. Yes, so sometimes this unnecessary compound will disturb, yeah, the activity of the bioactive compound, and also the quantity and the quantity of the product. So the more pure, the smaller, yeah, the material we use, yeah. The more crude, the the bigger, yeah, the more quantity to get what to optimize effect. Yeah, so of course we need extraction, yeah, before we do processing.
Okay, thank you, Prof. Hani. And there is a second question from Arika Indah, POLTEKKES Malang, ya. The experiment that has been described either in vivo, in vitro, or to the experimental animal, and how will it be applied to human later? Please, time is yours, Prof. Hani.
Yes. So in the development of product, yeah, for health, yeah, there are standard steps we have to follow. So before the product goes to human application, we have to make sure the quality, the efficacy, and the safety. Yeah, so the safety, of course, done in vitro and in animal, not in human. But for efficacy, we can test in human. Yeah, but for toxicity or safety, we do test in culture, yeah, in cell culture or in animal. Yeah, so this step, yeah, in vitro and preclinic and clinic, so we have to follow that rule. Yeah, if we want to especially produce a pharmaceutical product. But for food, yeah, maybe for food, less regulation. Yeah, for food, you can just do directly, yeah, to human. Yeah, because for food, normally safer than for drug. Yeah. So in the food development and the food product development for food application, so the regulation is less compared to product for pharmaceutical application. Yeah, supplement, for example, is in the category of pharmacy, but food actually less risk. Yeah, so you can produce a nanoparticle and then you can test to human is also allowed. Yeah, but of course under control. Yeah. But for drug or for supplement, so first before going to human application, we have to make sure the safety, the toxicity, yeah, and the quality, efficacy. Okay.
Okay, thank you, Prof. Hani. And there is one question again. It's from Bapak Ibnu Fajar, Politeknik Kesehatan Malang. The question is, how do we formulate a food with the help of nanotechnology to increase the appetite of children with malnutrition, especially stunting is file crew? Please, time is yours, Prof. Hani.
Yeah. So actually, the application of nanotechnology is to improve the properties of bioactive compound. Yeah. So vitamin, mineral, for example, yeah. So present in the food product, with, for example, the lipid soluble vitamin. So normally problem in the bioavailability, yeah, problem in the absorption. Yeah, so that's why we have to improve the absorption by using certain technique. One example is using nanotechnology if other technique cannot help. Yeah, so also the stability. Yeah, some of vitamin or major even 90% of vitamin is unstable. Yeah, oxidation by oxygen, photolytic, thermal degradation. Yeah, so we have to improve the stability by using nanotechnology, for example. So we encapsulate this compound, yeah, mineral, vitamin, using certain material. So by this encapsulation, we can improve the stability. Yeah. Also the odor, for example, yeah, the bad color. So we can protect, yeah, from this bad organoleptic property by encapsulating the compound in the nano carrier, for example. Yeah. So actually, if we really understand with the technology, the process, yeah, and the application, yeah, all problem can be solved. Yeah, either to improve the taste, to improve the stability, to improve the absorption, to improve the penetration, etc. So we can get from nanotechnology. But the important thing that we have to really understand how to produce the most suitable form of nanotechnology. Yeah, that's important. Is this answering your question?
Okay, thank you, Prof. Haini, about the explanation. And I want to ask to Prof. Haini, I know for your collaboration project in the SIG, MIRA MIT ITB Research Line on Progress, drug targeting for cancer therapy. It's what the source of plan maybe for make this drug, and maybe now how the result of the research.
Yes, actually, our proposal is exploring protein, yeah, from natural resources. So from Agaricus bisporus, yeah, from in Indonesia we call jamur kancing. Yeah, jamur kancing contain we call protein. Lead subunit mushroom tyrosinis. Ya, jadi protein attached with tyrosinis. Yeah, we know tyrosinis is enzyme. Yeah, to whiten the skin. Yeah, but this is the subunit of this. So we did many studies, yeah, to prove that this protein is really powerful as anti-cancer. Yeah, the mechanism of action of this protein actually improve the immune system, yeah, and also reduce the cell proliferation, yeah, reduce the improve the cell apoptosis, yeah, reduce the cell proliferation, and improve the immune system reaction. So these three things together is important to treat cancer cells, cancer tissue, or cancer organ. So with the MIT, so they are expert in the peptide, yeah, synthesis. So actually we propose the sequence of the protein, and then we just catch up the small sequence, yeah, which is really important for anti-cancer action. So they will do synthesis of this sequence, yeah, small peptide, yeah, and then we will do many experiments, yeah, to test the potential action of this small peptide as an anti-cancer agent. And then after that, we do formulation, we target, and yeah, all kind of experiment related to anti-cancer therapy.
from Henny Astuti, Prof. Henny,
Yeah.
about if we want to research about the effect on herb on muscle activity, should it be in the form of extract or nanoparticle? How to apply the result of this research if later in clinical research? Time is yours, Prof. Henny.
Please, I don't get the question. Please, one more.
Okay. If we want to research about the effect of an herbal on muscle activity, should it be in the form of extract or nanoparticle?
Okay.
How it apply the result of this research if later in clinical research?
Okay. So actually, if we want to know the benefit of nanotechnology on the herbal, of course we have to compare before and after. Before meaning extract, after meaning after form to nanoparticle, for example nanofiber or nanoparticle or whatsoever. So by comparing these two forms, we will conclude whether nanotechnology is really beneficial or not. If extract so better effect, then no use nanotechnology. But if nanoparticle showing significant effect compared to the extract, so then nanotechnology improve the effectivity of the extract. So we use nanoform, but of course we have to think a lot aspect. For example, when we get better effect on nanoparticle, then we have to think the economical aspect, the production aspect, and then the regulation. Whether, for example, small scale or lab scale can be brought to production scale. Because if we want to apply in clinic, so we have to produce in the lot of quantity, the big quantity. So meaning we have to do upscaling. So whether we can do upscaling from the lab scale to the production scale first. And then we have to think about the economical aspect. Whether the product with good characteristic affordable for people. If really expensive, then we have to think about, we have to compare between risk and the price. And the ratio between price and the benefit. Then the third thing, I forget what the last thing I just talked. Of course, the safety regulation. Nanoparticle, people say that nanoparticle is new material, but actually not. New characteristic is yes, but not new material. And this sometimes the regulatory body like Badan POM, they don't understand. Because they also don't have expert in nanotechnology, so they don't understand. So they ask many things. So they have many data which really prove the beneficial effect of nanotechnology is safety, efficacy, and other. So this all we have to think when we do research in nanotechnology. So
Thank
can
you,
be
Prof. Henny.
can
Thank you very
be
much.
better than nanoform or the other way around. But mostly nanoparticle is better than the raw material, the original extract.
Okay, thank you, Prof. Henny, about your explanation. And I think as enough the question and answers, and maybe I say thank you very much to Prof. Henny.
You're welcome.
Okay. And all right, that was an amazing discussion. I hope it's give inspiration for all us. It's a very, very interesting topic and very interesting presentation. And now time is must be running. before running, I will announce to all participants. We will share the link for material, so don't worry. Yeah, we will share the link for material, so don't worry. Okay. For presentation, okay, we are pleased to welcome Dr. Arif. How are you, Dr. Arif?
Okay, I'm pretty well, Sir Nur Rahman. How about you?
Okay, okay, okay. You have joined this this room. Okay, I will introduce Dr. Arif. I have to share the CV. Hello. Hello. Ms. Ola Ovina, please start the CV of Dr. Arif. Hello. Okay. Okay. Thank you. Thank you. Okay. Thank you. Thank you. Okay. Mr. Arif is he is a lecturer of Polytechnic Kesehatan Kemenkes Malang. His former education background is a student in doctoral program at Saint Paul University, Philippines. Teaching in several subjects such as medical surgery, surgical nursing, emergency nursing, and nursing. His research are the model of spiritual caring in nursing, development and evaluation of caring-based training program for Indonesian nurse. So, Dr. Arif, how are you?
I'm very well. How about you, sir?
Okay, your voice is little. I have to more loudly.
All right.
Okay, okay. And today he will be sharing with us her expert opinion on the importance of the strengthening spiritual belief in time of the COVID-19 pandemic, nursing perspective. With that, I ask that you give your full attention to Dr. Arif and help me in welcoming him to the stage. Dr. Arif, time is yours.
Thank you, Dr. Nur Rahman. Thank you for your kind introduction.
I have your louder, more louder, more louder.
Yes, sir. I will.
Next.
Once again, thank you, Dr. Nur Rahman.
Okay, okay.
Okay. I'll get started now. Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. It's great for me to be here with you. First of all, praise be to Allah subhanahu wa ta'ala, Lord of the world, who has granted his blessing today, so we can stay here till the last session. Secondly, I'd like to express my gratitude to the Director of POLTEKKES KEMENKES Malang, Bapak Budi Satya, SKP MKes, who gave me a valuable opportunity in this forum. Special thanks as well to Head of Nursing Department, Bapak Imam Subakti, SKP MKep SPCOM, who has offered me to be a speaker in this conference. My teachers, thank you for educating me. My colleague, thank you for your support. Actually, I'm not worthy to speak in this conference because lack of achievement, but you all, my colleagues, support me to accept this challenge to do better. Let me now present my paper entitled "The Importance of Strengthening Spiritual Belief During COVID-19 Pandemic." Yes, perhaps a question arose: why did I choose the theme? The answer is because I want every health professional, especially nurses, realizing that they should meet not only physical need of patients but also psychosocial spiritual needs, and that's called holistic care. And among these needs, spiritual needs are the most aspect of care that nurses often ignore. All right. Okay. Since it was declared a pandemic on March 11, 2020, a COVID pandemic has spread rapidly to 218 countries around the world today. Let's check this box. You can see here more than 60 million people has been infected by COVID-19, and at least 1.4 million people have lost their life. The data was taken 2 days ago, and you can see here this is the top 10 rank globally, and USA is the first top rank. All right. This is the rank of Indonesia. Yeah, the rank is always rising, and now Indonesia is ranked 21st globally and number 4 in Asia. I am sure that the ranking will rise if our governments will not treat it COVID-19 well. Okay, this is the impact of pandemic. The COVID-19 has a huge impact on many sectors, such as economical, political, educational, research, and healthcare sectors. In economical sectors, for example, many people have lost their job, reduced income, economic growth fell down, led to stress. The strategy of handling the COVID-19, like quarantine or social distancing, have restricted mass movement. A lot of people could not go to work. Students could not go to school. They work and studied at home by online. This led to stress. The data shown that the prevalence of psychological stress has reached more than 24% in general population, and not only affected to general people. The psychological stress is also experienced by healthcare workers, such as medical doctor, nurses, midwifery, etc. They got stressed due to COVID-19. There are many literature describe that the psychological stress, especially in the long term, may affect the immune system. The longer person experience stress, the more components of the immune system are affected. The chronic stress has detrimental effect on immunity, such as delaying the healing process of wound, increasing the severity and duration of infectious disease, promoting reactivation of latent viruses, and possibly even being a cofactor for tumor development and progression. On the other hand, there is no effective treatment for COVID-19. So far, the clinical management of patients with COVID-19 is mainly symptomatic. The management has been limited to support patients and provide palliative care. Various attempts have been made to control the disease, such as early diagnosis, tracing, reporting, isolating, improving personal hygiene, hand washing, wearing medical masks, adequate rest, keeping room well ventilated. But the prevalence of COVID-19 is still growing. To deal with COVID-19 at the same time, coping with psychological stress, strengthening of spiritual belief may be a solution. Spirituality, I believe, to be able to overcome psychological stress and increase the body immune system simultaneously. Given the important role of spirituality in coping with psychological stress, as well as maintaining or even promoting physical well-being of everyone, this paper is intended to present the impact of strengthening spiritual belief on psychological stress and human system immune during the COVID-19 pandemic. All right. The spiritual dimension is actually not something new in the nursing. It has roots in the past history. In her day, Florence Nightingale, the modern nursing pioneer, also tried to integrate spiritual care into the part of human needs and considered it a healing factor for patients. Unfortunately, spirituality is an abstract, intricate, elusive, and ambiguous concept. Every scholar, authors, even every person has different perspective, different perception, and definition upon the meaning of spirituality. What is clear is that spirituality is an important concept in the health science, as important as in business or managerial field. Generally, spirituality is associated with the need to find purpose and meaning in life, awareness of transcendence and connectedness with self, others, or beyond the self with something greater, higher being, God, something like that. Notwithstanding for the foregoing, spirituality nowadays has become an important aspect in nursing care. This, due to the spiritual care, becomes an accredited aspect. The Joint Commission on Accreditation of Healthcare Organization, or GCAHO, the largest healthcare accrediting body in the United States, for example, has mandated spiritual care in the hospital and healthcare facilities since 2001. I don't know in Indonesia whether spiritual care is an aspect which is accredited. Maybe participants who are attending here can explain this issue. All right. Once again, spiritual care in nursing is a critical part of providing holistic care. Nursing has applied a holistic approach in its practice since the 18th century. So, what is actually holistic? According to Merriam-Webster dictionary, holistic means relating to holism or concern with whole or with complete system. The whole is greater than the sum of its parts, expresses the essence of holism. Holism generally opposes the Western tendency toward analysis, the breaking down the whole into parts. Holism is an important concept in the sciences and social sciences, and especially in nursing, medicine. Holistic nursing tries to treat the whole person rather than focusing too narrowly on a single symptom. It emphasizes the connection between the mind and the body. Many ancient non-Western cultures embrace the holistic approach to health and illness, which includes a focus on interconnection between the mind, body, and spirit. Mind, yes, refer to mental processes, while the body is said to include the physical, biological, and chemical aspect of an individual. Spirituality is defined variously as existential reality, connectedness, and energy, or as a dimension of person that is concerned with the transcendent and life's meaning. Jean Watson, a distinguished nursing theorist, admits the unity of the mind, body, spirit in relation to the caring paradigm, which reflects a theory views human as a whole. The theory acknowledges the unique dimension of mind, body, spirit without compromising the wholeness of the person. The concept of wholeness then become one of major assumptions for a few middle-range theories about caring, such as the theory of caring the theory of nursing as caring by Boykin and Zonova, technology competency as caring in nursing by Loxin. He's a professor emeritus from nursing at Florida Atlantic University, Christine E. Ling College of Nursing, and now he's inaugural international nursing professor at the Institute of Health Biosciences, University of Tokushima in Tokushima, Japan. Lucky me, we became his student in the St. Paul University, Philippines. The concept of wholeness is also utilized in theory of unitary caring by Smith, and then the theory of caring by Swanson. I'm not, and I'm sure that my classmate in SPUP and colleague in POLTEKKES, Sarkisa, utilize this concept. You know, Sarkisa conducted grounded theory for his dissertation. His dissertation entitled "Technological Creativity is Caring in Nursing, if I'm not mistaken." Last time I had he submitted his research in the reputable international journal, and I hope his article has been accepted and published internationally. We hope that next year he will get an opportunity, just like this event, to introduce and socialize this his theory. Okay, and then the biopsychosocial model is a modern humanistic and holistic view of the human being. The model was brought to medicine by George L. Angel in 1999, a prominent scholar engaged in the psychosomatic movement. Currently, many researchers think the biosocial model should be expanded to include the spiritual dimension as well. All right. The World Health Organization (WHO) incorporated a spiritual aspect to its constitution at its 52nd Assembly meeting in 1999. The amendment becomes health is a dynamic state of complete physical, mental, spiritual, and social well-being, and not merely in the absence of disease or infirmity. Considering the description above, holistic nursing is then defined as all nursing practices that has aimed to heal the person as a whole. As a holistic approach, spiritual care has unique main characteristics such as healing presence, therapeutic use of self, intuitive sense, exploration of the spiritual perspective, patient-centeredness, meaning-centered therapeutic intervention, and so on. Before spiritual care is delivered, nurses should be getting ready and pay attention to the transcendent awareness, self-awareness, religion affiliation, professional commitment, sensitivity, and intentionality, both nurses and patient. The delivery of spiritual care eventually leads to positive consequences such as healing, promotion of spiritual well-being, psychological adaptation, and feelings of satisfaction for patient, and promotion of spiritual awareness and job satisfaction for nurses. All right, this the book Nursing Diagnosis, Definition, and Classification. I think this book can be a framework for nurses. The book lists three nurses' diagnoses in relation to the spirituality, namely spiritual distress, risk for spiritual distress, and readiness for enhanced spiritual well-being. Spiritual distress is the important issue in patient response to the health problem and is listed in the Taxonomy 2 of Nanda International as nursing diagnosis since 1978. In that book, it is briefly described a definition of spiritual distress, defining characteristic and related factors. Likewise, different nursing interventions have been described as adequate in supporting patients in overcoming spiritual distress, such as music therapy, guided imaging, therapeutic touch, and effective support group and meditation. All right, patients who are spiritual may utilize their belief in coping with illness, pain, or life stresses. Some studies indicate that those who are spiritual tend to have a more positive outlook and a better quality of life. For example, patients with advanced cancer who found comfort from their religious and spiritual belief were more satisfied with their life, were happier, and had less pain. Spiritual belief also assisted people to cope with difficult aspects of living with a chronic illness. Watson indicated in one of her major concept, Caritas Processes, the importance of the spiritual dimension for the person being cared for. She stressed the importance of the cultivation of one's own spiritual practices and transpersonal self, creating a healing environment at all levels, physical, non-physical, subtle environment of energy and consciousness, whereby wholeness, beauty, comfort, dignity, and peace are potentiated, and opening or attaining to spiritual, mysterious, and existential, uh, all right, an existential dimension of one's own life death, soul care for self and the one being cared for, allowing for miracles. All right. On the other hand, Swanson said that at the very core of caring, when the provider maintains a belief in others' capacity to come through an event and transition and face a future with meaning, the recipient feels hopeful. Yeah? That is opposed to the hopeless. This hope does not mean that sickness, sorrow, fear, or loss will not unfold as it must. Rather, it is hope that the recipient will be able to get through the situation and find meaning and purpose in whatever comes next. All right, this is the impact of strengthening spiritual belief on psychological stress, and this is the evidence base. Spiritual belief were reported to play a major role in the stress management. Spiritual belief is also one of ways in coping with spiritual distress. Spiritual belief every day has been also reported increasing the level of positive mood, decreasing the level of negative mood. And then this is the impact of strengthening spiritual belief on psychological stress. Moreover, people reporting no spiritual belief have not resolved their grief by 14 months after the death. People who profess stronger spiritual belief seem to resolve their grief more rapidly and completely after the death of a close person than do people with no spiritual belief. Koenig, 2012, stated that spirituality is beneficial for people in coping with a wide range of illnesses or in a variety of stressful situations. He further reported that studies on spirituality show significant results in increasing positive emotion, such as increased well-being, hope, optimism, meaning, and purpose in life, a sense of control over stressful situations, positive characteristic traits. In contrast, he also reported decreased level of depression, incident of suicide, and level of anxiety and fear. Okay, and then the impact of strengthening spiritual belief on immune system. In line with its role in coping with psychological stress, spiritual intervention in most previous studies has also been reported in enhancing the immune function. People who had more spiritualities indicate a higher total lymphocyte count, total T cell count, and helper T cell count. In addition, the importance of spiritual expression was associated with significantly higher white blood cell count, total lymphocyte count, total T cell and cytotoxic T cell activity. There are also a number of studies reported that people with HIV had significantly lower infection rate or lower viral loads. Okay, this is the last slide, the last presentation. In conclusion, strengthening spiritual belief is essential nursing intervention for those facing crisis situations such as the COVID-19 pandemic. Strengthening spiritual belief is expected not only to be able to overcome psychological stress, but will also increase the immune system. For this reason, research is needed to further explore the impact of spiritual belief on both psychological problems and people's immune system during the COVID-19 pandemic, so that the intervention can be applied in the professional practice setting. That's all my presentation. I give it back to you, Dr. Nur Rahman, and thank you.
Baik, Pak Nur.
Oh, okay. Thank you, Miss Dr. Arif. It's very interesting presentation and very interesting topic, and it gave positive stimulation to us all. And for better understanding, I would like to ask the interpreter to read the Indonesian translation for the conclusion of Dr. Arif presentation. Hello, Nabila.
Yes, sir.
Are you ready?
Yes, I'm ready.
Okay. Miss Nabila, time is yours.
Okay, thank you, Pak Rahman, for the opportunity. I would like to deliver my brief summary of Dr. Arif Bastiar presentation in Bahasa. COVID-19 telah membawa dampak yang sangat luar biasa pada berbagai sektor. Berita mengenai transmisi, karantina, aturan social distancing, dan strategi pengendalian COVID-19 menjadi penyebab psychological stress atau tekanan psikologis. Spiritual menjadi aspek penting dalam pemberian asuhan keperawatan secara holistik, dan penguatan spiritual dipercaya memiliki peran dalam manajemen stres. Berdasarkan penelitian beliau, dimaksudkan untuk menyajikan dampak penguatan spiritual pada tekanan psikologis dan kekebalan tubuh manusia pada era pandemi COVID-19. Dan dari hasil yang telah didapatkan, dapat disimpulkan bahwa penguatan spiritual dipercaya sebagai intervensi keperawatan esensial dalam menghadapi situasi krisis pandemi COVID-19 yang tidak hanya dapat mengatasi psychological stress, akan tetapi penguatan spiritual juga dapat meningkatkan imunitas tubuh terhadap infeksi suatu penyakit. I think enough for my explanation, and for the next I will give it back to Pak Nur Rahman. Thank you and good morning. Pak Nur Rahman, I think you are still in a mute mode.
Okay. Thank you, Miss Nabila.
You're welcome.
As better understanding for participant, because many participant is from Indonesian, so it should like to translate in Indonesian. And thank you, Miss Nabila. Now entering the question and answer session, I invite one question first from the participant. You can write question in the chat box under the format name, institution, and question. Question in English are preferable. Is there? Oh, there is. Okay. Okay. Now I will read question from the chat box. Okay. It's from the Mrs. Anisandra and Miss Arika. It's in Indonesia. Bagaimana cara mengukur bahwa spiritual seseorang bias lebih kuat atau bisa lebih kuat dari sebelumnya, ya? Bisa lebih kuat dari sebelumnya. Okay, time is yours.
Okay, sir.
Dr. Arif.
Should I answer in Indonesia too? Should I answer the question in Indonesia too?
Okay, in English, please, in English.
In English, okay. Alright, the question is, bagaimana cara mengukur bahwa spiritual seseorang bisa lebih kuat dari sebelumnya? Yes. Alright, thank you. It is a very challenging question. I think it is about how to measure the spiritual in the person. Yes, I think spirituality is different every person's. Even every author, every scholar is different to define the terminology. So I think, according me, how to measure the spiritual, the one spiritual that increased than before. I embrace Islam as a religion, and in the religion, in the Islam, also teach us about the spirituality. So I think spirituality is different with religion. when we want to know how to know that our faith, our spirituality in Indonesian maybe iman that increase if, for example, if I do pray, if I read the Holy Quran, if we feel something that uncomfortable, and that's mean that our spiritual is not good. So I think if you practice spirituality, if you are Muslim, you can do pray, you can do tilawah Al-Quran or something like that, and your heart, you feel serene, you feel peace in your heart. That's mean that your spirituality is increased. I think I hope this answers your question. Thank you.
From Miss. Thank you, Dr. Arif, about your explanation. Question from Mrs. Anisendra and Mrs. Arika. And the second question is from Alvina. Really, the question is, how do we create awareness to ourselves to encourage well-being, spiritual health? How do we create awareness to ourselves to encourage well-being, spiritual health?
Okay,
Please. Yeah.
Thank you. This question is very good question, I think. The question is how to uh,
how do we create?
How do we create?
Create.
Yes. Yes. Once more, that spirituality is different from others. Different is from each others. So, if you are Muslim, how to create spirituality, spiritual.
Yeah.
Excuse me.
Okay. Next. Continue, please. Okay. Continue, please.
Okay. I lost the questions. Would you like to repeat more? Repeat the question. Sorry. How to create?
How do we create awareness to ourselves to encourage well-being, spiritual health?
All right. How do we create spiritual
Awareness.
To our?
How do we create awareness to ourselves to encourage well-being, spiritual health?
Okay. I tell you truth that to answer in English is very difficult for me, but I try to answer the question. How to create the spiritual nurse to do better, to meet the spiritual need of the patient. Yes, the first of all, I would say that spiritual practices can deliver to the patients by very various practices. For example, if you listen to the patient actively, I mean full pay attentively, and you give the patient time for express their feelings, and the patient will get yes, I think the patient will the patient will feel good or comfort. So in this case, everything we do to person to make it to make it their hearts comfort, to make it their heart comfort, serene or peace. This is the spiritual practices. So it is not only related to the spiritual religion activities, for example, prayer or reading the holy book, etc. But everything we can do to patient that make it the heart more comfortable, more happier, or something like that. This is the spiritual care. So I think we must practice by own self to do that. So we can encourage patient to do what we have practices every day. That's all I think. Hope that answers your question. Thank you.
Okay, thank you, Dr. Arif.
Donor, may I ask Dr. Arif?
Okay, Mr. Kisa, please.
Thank you for the opportunity. Congratulations, Dr. Arif.
Very welcome, Sir Kisa.
Hey, thank you for introducing my theory. Hey,
Yes.
I would like to ask you, a while ago you said about religion and spirituality. Could you explain in detail what is the difference between religion and spirituality? Because oftentimes is interchangeable. And how about the atheist people? They have spirituality, or what do you think? What do you think about it? Thank you.
All right.
Okay.
All right. Thank you, Sir Kisa. That is a really good question and challenging, I think. Your question is about what is the difference between religion and spirituality. Yes, as you said that scholar has different opinion regarding with the terminologies. Some of them view the terminology just the same and use it interchangeably in the literature or references. Some other view difference. So according to me, religion is different with spirituality in terms of scope of each terminology. Religion is not only limited to belief, ritual or ceremonies, but it is broader than that. Religion is a way of life that, according to me, consists of ideological, political, economical, social, and other aspects of our life, including individual spiritual needs. So, as we know that when we talk about human, for example, they are made of matter, which compose our body, and then something immaterial, we call that spirit or soul. From this word, spirituals comes from. Each part has own needs, just as our bodies need something material. Our soul also need something immaterial. So, for example, prayer or read the holy book, yeah, something like that. It is not something material but immaterial. For example, if we feel hungry, what we do? Yes, I think we need to eat. Yeah. If we feel thirsty, yeah, we need to drink. So now, how about if we feel unserene or not in at peace? Yes, we need spiritual practices to feel it. So I think every human being differently has spiritual needs, regardless of whether she or he embraces a particular religion, but or he or she is an atheist or agnostic, because of people have two to composition, that is material, that's our body, and something that material, that is spirit or soul. That's all I think. Hope this answered your question. Thank you.
Thank you, Dr. Arif. We have answered 3 questions, but there is one question more. Have you any time to answer, Dr. Arif?
Yes, sir.
There is one question more. Do you have any time to answer?
I'll try to answer the question, sir.
Yeah. Okay. It's from Mr. Ibnu Fajar. How is different between mainstream music and religious music in order to fight for psychological stress during pandemic?
Yes, sir. All right. Thank you very much to Bapak Ibnu Fajar that has proposed the questions. That I think that is very good questions. Talking about the music, is there any influence maybe? Oh, no. Is there any difference between mainstream music and religious music in order to fight or for psychological stress? Yes. Yes. First of all, I would like to repeat my statement earlier that spirituality is different from each other, meaning to say that I have different background with others. So if someone, when he enjoy the pop music or rock music or something like that, others maybe enjoy religious music, as long as the music will cause the heart at peace. I think we can say that the music have the influence. So depend on the person, I think. Of course there is difference. Maybe I like religious music, but I don't I dislike the other music. If I try to listen the other music, my heart becomes headache because I dislike that. But when I listen the music, religious music, so I will have comfort of that. So I think, but there is people when she listen to the melancholic music, maybe he will get headache because there is unsuitable for his heart. Maybe they like the music like rock or something like that. Different people, different feelings. So we are unique and depend on the preference. We should give a patient a different intervention. Yes, I think that's all, Dr. Nur Rahman. Thank you.
Thank you, Thank you, Dr. Arif. So we
Very
can
welcome, sir.
recommend to use religious music to fight or psychological stress.
Yes. Thank you, sir.
Okay.
Thank you.
Okay, thank you, Dr. Arif. You have answer for question. It's many time. I'm sorry, but okay. I'm say thank you very much to Dr. Arif. All right, that was an amazing discussion.
Pak
I
Nur.
hope.
Pak
Okay.
Nur.
Okay. Dr. Putu.
One more.
Okay. Okay. Thank you. Please. Yeah.
Yeah. Thank you, Pak Nur Rahman.
Yeah.
For Dr. Arif.
Yes, ma'am.
Hello,
Yes,
Dr. Arif.
Yes, ma'am.
Now, POLTEKKES Malang has a COVID
19 task force. Until now, severe students have been infected with COVID-19. I think my opinion is Dr. Arif can apply the result your research to keep for the student who have been infected COVID-19. You can ask counselor for the students who infected with COVID-19. I have, you can applicate your result, the research.
The research.
That's this, Dr. Arif. Thank you, Pak Nur.
Okay, thank you. Thank you, Mrs. Putu. Maybe I hope Dr. Arif explain about the question from Dr. Putu. Please, Dr. Arif.
Yes, I think that is not a question but a request. In order I to be an advisors of students for the thesis. I think it's okay, Dr. Putu.
Yeah, thank you. Sukses, Dr. Arif.
Thank you very much.
Yeah.
Okay.
Sir Nur Rahman, can I give one more point of my presentation? Okay. I want to express that how amazing our spirituality, based on the book of biological of belief. This book is written by Bruce Lipton. He's an expert on epigenetic. He says that in his book, every human being has 50 until 100 million cells that compose our bodies. So our bodies are actually the entities of trillion of cells. Just like human, cells are also influenced by environment. If we perceive that there is something dangerous in front of us, our thinking will send the message to the cell that there will be a threat. We call this epigenetic. What we think in our mind will control our cell behaviors. As consequences, the cell will undergo stress. In that situation, the cell will protect rather grow itself. The cell then will shut down a certain process in the body. One of them is immune system. Now, what do you think? If the immune system shut down, people will be susceptible to infection. As I stated earlier in my presentation, that bad news of the COVID-19 was so massive in media. Have we ever realized that the massive bad news will influence our body cells? Let's now take a look in the COVID-19 prevalence and mortality. How many people have infected the COVID-19? Almost more than 60 million people nowadays got infection. Among them, how many people did develop into critical state? How many people has died by the COVID-19? Vast majority of patients actually, in fact, showed mild symptom. Less than 1% in critical condition and 3% death. So just imagine. Do we know that why so many American infected? We know that American is the top rank in the prevalence of COVID-19. So do we know that actually why so many American infected by the COVID-19? 2/3 population there at least has one medical condition. 1/3 has two or more medical condition. This medical condition is stresses, and when the cell undergoes stress, the immune system will be compromised, will shut down. Guess what the next? Yes, you're right. Patient will be infected easily and die. In this circumstance, strengthening our belief to ourselves and Almighty God is very important. Believe in ourselves that COVID-19 is not dangerous threat. Once more, believe in yourself that COVID-19 is not a dangerous threat. Believe in yourself that we can survive from the COVID-19. Believe in an Almighty God who will help us from the COVID-19, will make our head calm, peace. Therefore, our cell will grow and immune system will function properly to prevent infection. I think that's all my point. Thank you very much.
Okay, thank you, Dr. Ari, about your explanation. Okay, all right. It was an amazing discussion, and I hope it gives inspiration for all us. All right, that was an amazing discussion for amazing speaker. I hope it gives inspiration for all of us in maintaining the food, nutrition, and health. Lastly, I would like to summarize the discussion which I have taken in my notes. First, from Dr. Graham, that evidence-based practice in midwifery is a problem-solving approach to the delivery of midwifery care that integrate the best evidence from research, midwife expertise, and patient preference and value. From Dr. Pantan, that electronic health record program in Vietnam are considered as an effective system in order to collect data that are also filtered by prevention program information system. From Dr. Henny, that's nanoprocessing for tropical plant to improve their function for food and medicine are proven to be quite effective in some of the plant being researched. And the last from Dr. Arif, holistic nursing spiritual support method is needed in order to cope the psychological issue related to COVID-19 and immune system among individuals. Okay, it's such a nice opportunity for me to lead this event. That's all from me, and I will give it back to the Mr. Ceremony, Ms. Siva. Wassalamualaikum warahmatullahi wabarakatuh. Thank you, thank you, thank you.
Waalaikumsalam warahmatullahi wabarakatuh.
Okay, thank you for our moderator, Dr. Nur Rahman, and also thank you so much for all the speakers with an excellent topic. Okay, so for all the participants and audience, please fill the evaluation form at the following link. We will also write down the link in the chat box on Zoom and YouTube. You can fill the form at bit.ly/evaluation third ICFNH. Once again, you can fill the form at bit.ly/evaluation third ICFNH. Please fill in with your full name and an active email address. Okay, thank you. While filling out the evaluation form, I will announce the result of the oral presentation and poster polling from yesterday. One best oral presentation will be chosen from each room and 3 best poster from the polling result. So there are 10 in total. Let's start with oral presentation first. Okay. The best oral presentation in 3rd International Conference Food, Nutrition, and Health POLTEKKES KEMENKES Malang 2020. The winner from room 1 goes to Farah Mayuda, MSc, from SF ITB and FF Unjani, with the title Potential of Cat Whisker, Orthosipon aristatus plumic as antiviral, mini review. The next, the winner from room 2 is Kisa Bahari, SKEP Nurse MKEP PhD Nurse from POLTEKKES Kemenkes Malang. The title, The Effectiveness of Social Skill Training Towards Social Interaction Skill on Autism Children. Next, the winner from room 3 is Wahyu Setianingsi, SST MKes from POLTEKKES Kemenkes Malang, with the title, The Role of Mother in Fulfilling Nutrition Needs Impact Adolescent Nutrition Status. The winner from room 4 is Fadilah Rizky Ahmada, STRKEP from POLTEKKES Kemenkes Malang, with the title, Relationship Between Adolescent Pregnancy and the Incidence of Postpartum Depression. Okay, next, the winner from room 5 is Sinta Kristianti, SSIP MKes from POLTEKKES Kemenkes Malang, with the title Reminder System Models in Increasing Compliance to ARV Consumption on Women with HIV in Kediri. Okay, the winner from room 6 is Aisyah Zahra from POLTEKKES Kemenkes Malang, with the title The Effectiveness of Media Comic Education as a Socialization Tool about Triad KRR for Teenagers to the Level of Knowledge Teenagers in Posyandu Ribuan Syah Krebet Village. And the last, the winner from room 7 is Anggi Ardiasti MPH from POLTEKKES Kemenkes Malang, with the title Willingness to Join National Health Insurance in Tulungagung, Indonesia, a Qualitative Study. So that's all the result from oral presentation. Now we move to best poster from the polling result. Okay, the winner. The first winner is poster number 4. The first winner, poster number 4 from Karisa Cerdasari Antip, with the title Nutritional Status, Dietary Pattern, and Healthy Lifestyle Practice Among College Students During COVID-19 Pandemic. The second winner goes to Naimah and Wahyu Setianingsi, with the title The Effect of Gravidiary Android-Based Application on the Knowledge and Attitudes of Pregnant Women. And the third winner goes to Dwi Fitri Wulandari and team, with the title Factors Influencing the Interpregnancy Interval of Childbearing Age Couple. Okay, so that's all the winner. Congratulations. And for all the winners, you will get a certificate which will be sent by the committee. Once again, congratulations for all the winners. Okay, ladies and gentlemen, we now come to the end of the international conference in celebration of 19 Disnatalis of POLTEKKES Kemenkes Malang. But before that, let us listen to the closing statement that will be delivered by chairs of the committee and head of Education Development Center of POLTEKKES Kemenkes Malang. Dr. Anasari Mustafa, time is yours.
Thank you, Mbak Siva. Good afternoon and Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
The Honorable Director of State Health Polytechnic of Malang, Bapak Budi Satya SKP MKes, the respectable Vice Director 1, 2, and 3 of State Health Polytechnic of Malang, along with the rank, Head of Department of Nutrition, Nursing, Midwifery, and Applied Health Science of State Health Polytechnic of Malang, along with the rank. All the speakers who have delivered their material in this event, invitees and all participants of the conference, and most dearly my fellow committee of the conference who have been fulfilling their duties to keep the conference run smoothly. Praises and thanks we always give the presence of Allah Subhanahu wa Ta'ala, the Almighty God, of all His blessings to have keep us safe and able to complete the third international conference of the State Health Polytechnic of Malang. Today, Thursday, 26th of November 2020, this conference has completed well and smoothly all process of the third international conference on food, nutrition, and health with the State Health Polytechnic of Malang have held and organized. During the conference, main sessions, 9 distinguished invited speakers who are leading experts in their field. We already delivered speech or papers. Five invited speakers. They are Professor Amin Ismail from University of Putra, Malaysia. Dr. Mois Al-Islam from Dubai, Professor Wakisaka Minato from Japan, Prof. Malin Ungsurungsi from Thailand, Dr. Elvira L. Urgal from Philippines, guided by Dr. Barokatun Nisa from University of Putra, Malaysia. And the second day of the conference, there is 4 invited speakers have delivered their papers. In the second plenary sessions, there are Kristen Graham from Australia, Pantan from Taiwan, Prof. Heni Rahmawati from Bandung Technology Institute, and Dr. Arif Bahtiar from Polytechnic of Health Malang, Indonesia. The second plenary session was moderated by Dr. Nur Rahman, SDPMP, Coordinator of Center of Excellence, IPE and IPC, and Lecturer of State Health Polytechnic of Malang as a moderator. And also, we already know the winner from the presenter of oral presentation and also from the poster. For the winner, for all the winners, I would like to say congratulations, and the winning certificate will be presented by the Director of State Polytechnic of Malang. And the whole process in the second days of the conference has been going on well and smoothly. In the second day of the conference, the number of participants joining through this Zoom meeting around 100, and also from the YouTube around 36 people. But from the international conference yesterday, that's the participant by Zoom meeting around 290, and from the YouTube around more than 500. So that is all the announcements from the International Conference of State Health Polytechnic of Malang. My deep thanks to all conference participants and speakers, to my fellow committees for your participation and involvement. Please apologize if there is any of our services during this conference have not met with your expectations. Before I finish this speech, I will deliver a statement from a world figure. It is health that is real wealth, and not pieces of gold and silver, Mahatma Gandhi. With the completion of this event, we would be grateful, and by saying Alhamdulillahirabbil Alamin, the third international conference of the Health Polytechnic of Malang, Ministry of Health Malang, I now declare is officially closed. Thank you very much. Good afternoon and Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Dr. Anasari Mustafa.
Assalamualaikum warahmatullahi wabarakatuh.
Ladies and gentlemen, this is the end of the 3rd International Conference on Food, Nutrition and Health 2020. Lastly, on behalf of the entire committee, I would like to extend our deepest appreciation to you all for your support in participation. And hopefully this conference can be useful for all of us. Once again, thank you and good afternoon. Selamat siang. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
warahmatullahi wabarakatuh.
Thank you. Congratulations for Mr.
Thank you for all on the committee and also
Congrats.
and Asifa and Alvina
and all the committees. Okay.
Terima kasih. Terima
In the
kasih
next
semua
international conference.
seluruh panitia.
Halo Pak Arif. Thank you for director for. Wah, Pak Arif tinggal sholat.
Keren Bu Ana, selamat ya.
Thank you, Mbak Tafi.
Thank you. Congratulations for all.
Selamat Bu Ana.
Ya, terima kasih semua.
Bu Ana, cita-citanya udah tercapai, cita-citanya.
Cita-cita apa tuh?
Cita-cita internasional conference-nya sukses.
Alhamdulillah. Supportnya teman-teman semua. Terus berkat kompakan dari teman-teman semua.
Tinggal syukurannya ya Bu.
Oh ya, insya Allah.
Daring Bu Taufik.